Yeah. Ma'am, you can start now.
Yeah. Good evening,
Okay,
everyone.
1, 2, 3.
Namaskar, and welcome you all in this unique FOGSI ICOG webinar, and that is Chai Pe Charcha. And this is actually thought of ICOG chairperson, Dr. Lakshmi Shrikhande madam, that she has given such a beautiful name that with chai, tea, it is always energetic and always keep us very active. So during this Charcha, we will have some important relevant discussions on very important clinical topics. And today we have as a chief guest Dr. Rishikesh Pai sir. He will join us soon. Till that, we start the session, and we have as a guest of honor none other than our FOGSI secretary, Dr. Madhuri Patel madam. So I just introduce madam and ICOD chairperson. Before that, I will just beautiful inauguration by name of Shri Ganesha, and then we come to Dr. Madhuri Patel madam. We all know that she is the Secretary General FOGSI, former committee member FICO preterm birth, Associate Editor General of Obs and Gynae of India, Honorable Clinical Associate, Wadia Hospital, Patel, Mumbai.
Okay, Bharti. Okay, Bharti.
So we all know that beside that, so much of academic qualifications, madam is a very humble and very sweet human being. So I request Madhuri Patel madam to address as a guest of honor. Yes, madam.
Thank you, Bharti, for your kind and warm words. Our respected ICOG chairperson, Dr. Lakshmi. Of course, before that, I have to talk about Dr. Rishikesh Pai, our president FOGSI, very dynamic, and of course, a visionary. And I can see Lakshmi, and we are friends since I think last 30 years. And we have been, into all this academic and, as a family friend also since last 30 years. And the Lakshmi has done so many series, 1, 2, 3, 4, 5, 6, 7, 8. And now this is the Chai Pe within 4 months. I'm just counting because I'm sitting in the office and I say, I want to know, how many series you have done. So this time Chai Pe Charcha, it has been said, and now Lakshmi is following Dr. and Mr. Modi's Shri Prime Minister Modi footstep, and which I always like that Chai Pe Charcha. So now Lakshmi, this is also going to be very, very popular Chai Pe Charcha. And you have given a half-an-hour slot. So that is the most important thing we have to tell to all our delegates. And of course, Bharti as a series convener is doing wonderful job. She's into it and she is trying to help everybody out of this to give the best. So Bharti, thank you very much. And of course, we have Parag. Then we have Dr. Ashok Kumar. Parag again, I know him since, Lakshmi, I know Parag from so many years. And Dr. Ashok Kumar, we all are good friends. And Dr. Sarita, then my Dr. Harish Doshi, Manu Chelani, and my Dr. Mala, Dr. Jyoti, and all over here are there. Very good evening to all of you. At the outset, I would like to thank Dr. Rishikesh and ICOG team for giving me this opportunity. And what Lakshmi is, our college, Indian College of Obstetrician and Gynaecology, is the academic wing of FOGSI. And it is an excellent work, and we are hoping to come out with in future, ICOG college like CPS, where we can give the benefit to our Indian, MBBS who never got, post or qualification. So if we can come out with that, Lakshmi and myself will definitely try our best to do that. So this is the only message I want to give, that we as an obstetrician are doing great work in reduction of maternal mortality rate, which is today 97 per 100,000 labor. And we are going to achieve very soon, the SDG by 2030, that is less than MMR less than 70 per 100,000 labor. Let me share with you that what the whole world, WHO, FIGO, and all the donors, they are interested in reduction in maternal mortality rate. So they are selecting our high risk, maternal mortality rate, areas. And we are going to work with them, and we have been working. So Lakshmi, this will also help us, your today's, in not only the mother, but also our babies, neonates and perinates, for this. So I congratulate you for the most app, this Chai Pe Charcha, academics, and wish you all the best for your future endeavor. Thank you once again.
Thank you. Thank you so much, Madhuri. Thank you.
Thank you, madam. And now we have none other than our guest of honor, Dr. Lakshmi Shrikhande, madam. We all know that she is a chairperson ICOG and doing a wonderful job in academic as well as all postgraduate trainings as well as for the FOGSI. So now to Dr. Lakshmi Shrikhande, madam, for this program.
Yes, you can stop screen sharing,
Yeah.
Bharti. As Madhuri has taken everyone's name, so I will not take everyone's name. Friends, good evening, everyone, and I am so happy that Bharti has taken the responsibility of being the series convener for Chai Pe Charcha, where she will come out with one practical topic which really needs discussion, and discussion can best happen over chai. So this today's topic is also, can we reduce cesarean section? I don't have any answer, but Bharti is trying that can we reduce cesarean section, we all being obstetricians, by improving or enhancing our obstetric skills. So I'm really hoping that after this Chai Pe Charcha, I mean, it will really work and encourage everyone to try to reduce cesarean section. As all the details of this I will be covering in my talk, as I am the opening batsman. I take this opportunity to welcome, I can see Dr. Madhuri Patel is here, our FOGSI president, Dr. Rishikesh Pai, Parag, Ashok, series convener Bharti Maheshwari, all my ICOG governing council members, and all the faculties, chairpersons, speakers, experts, and all dear delegates who have logged in for this very, very practical discussion on can we reduce cesarean section rate. So once again, welcome, and I hand over back to Bharti to start with the scientific program.
Thank you, madam. And now we start the scientific session, and we invite the chairperson, Dr. Parag Bini Wale sir. He is a vice chairperson ICOG, we all know. And Dr. Parag Bini Wale sir is a, we all know that he is a very academic and helping person. We have got lots of ICOG creditors. If we even forget, he used to do mail or call ki you just apply for this. And he is a senior consultant at the Pune, PG teacher, unit head, Kamala Nehru Hospital, President Menopause Society, Pune, Pune Obs and Gynae Society, National
Thank
Joint
you,
Secretary.
Bharti. Thank you.
Yeah, so we just say a few words. And another chairperson I am just introducing, Dr. Ashok Kumar sir. He is a director, professor, and head department of Obs and Gynae, Atal Bihari Vajpayee Institute of Medical Sciences, Ram Manohar Lohia Hospital, New Delhi, and he is a secretary ICOG. We all know sir's academic input and
Thank
her
you,
tireless
Dr.
work.
Bharti.
So now
I think
I invite both
Bharti,
chairpersons.
Bharti, let's
Bharti, we
introduce
continue
everyone
with the
in
talk.
2 lines, and please don't introduce me, so that I can start with
We
the
continue
topic.
with the talk. Yes.
You
So
all
now,
can share your
chairperson.
thoughts after my talk is over, because that will be really much helpful for all our delegates. So because Ashok Kumar is the professor and Parag is in the private practice, so as a chairperson you can give both public private your ideas both in the public sector and private sector. Meantime, where my PPT has gone, final actual.
Okay.
I was trying to share. Bharti, have you stopped screen sharing? Why I'm not able
I
to
have
share
stopped,
this?
madam. You can.
Yeah, I'm just trying to search my.
So till then, I think I'll make some opening remarks. Thank
Yeah,
you,
yeah,
Bharti, for those kind words.
I'm just searching my PPT. Use, please.
It is indeed a pleasure to welcome you all
Can you
on
all
behalf of
see,
the ICOG.
Parag, sorry to interrupt you. Can you see my PPT?
Yes, we can. Just
Actual
put it on. Yeah, that's it.
Yeah.
Right. C-section is something which is on the rise, and this is a matter of concern for all of us. A lot has been happening as far as the maternal health is concerned, and rising C-section rate is something which we all as obstetricians must look at. Eyebrows are being raised because the rate is rising, and apparently people feel that we are not doing much about it, but that's not true. We as an organization for women's health is doing a lot of effort to ensure that the birth is safe and the C-section rate is controlled. So what is the current C-section rate? Let's hear it from the chairperson ICOG, Dr. Lakshmi Shrikande. Lakshmi, over to you for the opening.
Thank you, Parag, for your opening remarks. Friends, what WHO says about cesarean section as a mode of delivery. Cesarean section is a surgical procedure that can effectively prevent maternal and newborn mortality when used for medically indicated reasons. These three words are very, very important. But as with any surgery, cesarean sections are associated with short and long-term risk, which can extend to many years beyond the current delivery, and it can affect the health of the woman, her child, and her future pregnancies. These risks are higher in women, those who are having limited access to comprehensive obstetric care. And that is why now everyone is concerned and everyone wants to reduce the rates of cesarean section. These are the potential short-term complications for the child, for the mother, but just have a look at the long-term complications as well. And these long-term complications are for the child, that is increased risk of asthma, obesity, and for the mother also, it has a long-term complications. So in 1985, WHO came out with a statement that the international community has considered a range of 10 to 15% to be the ideal rate of C-section in a country. Since then, C-section rates have become increasingly common in both developed and developing countries. We know that it can efficaciously prevent maternal and perinatal mortality and morbidity. But let us see at the world demography. According to the new research from WHO, cesarean section use continues to rise globally, now accounting for 1 in 5 of all childbirths. This number is set to continue increasing over the coming decade, with nearly a third of all births likely to take place by cesarean section by 2030. And as you can see in this graph, the rate is increasing worldwide, and therefore governments and clinicians, they have expressed their concern about the rise in this number and the potential negative consequences of maternal and neonatal health. Now let us have a look at the India demography. We all know that it is definitely increasing in developing countries, including India. And in terms of developing countries, the cesarean section rate have crossed the WHO threshold, where all controversies started, as WHO has given a threshold of 15%. Nearly half of the total C-section births, they are taking place at private health facilities in urban areas. That is also a cause for concern. And most people, they are choosing private health facilities over public ones. Let us have a look at the state demography. You can see that the states that have recorded a jump in cesarean births are Andhra Pradesh, Arunachal Pradesh, Chhattisgarh, and Assam. So this is in detail the state-wise distribution of C-section rate, and this data is from National Family Health Survey 4. What is more evident that in this fourth survey, the northeast area was in blue zone. That is, cesarean section rate was below the threshold. But as you can see that in the fifth survey, even northeast states, they are coming and they are having C-section rates rising. And what are the reasons for this rise in C-section? One of the most crucial reason is the increase of institutional births, and the other attributable factors are unregulated health facilities, mainly private institutions, and an increasing number of women who are opting for private health facilities. Remember, according to WHO, these factors are regarded as non-clinical factors. WHO is not telling us to have a control over medical or obstetric indications. everyone is propagating that non-clinical factors needs to be explored and understood so that we can reduce the C-section rate. So as you can see in there are health implications, increasing literacy education, private deliveries, financial incentives, socio-cultural factors, all these things leads to increase in C-section rate. But are these C-section surgeries in India are rising as they are saving more mother and newborn lives from birth complications, or they are surgically deliveries being driven by commercial interest and other non-medical reasons? This is the big thought and it really needs serious chai pe charcha. As you all can see, the livelihood of women and their families in the context of developing countries plays a significant role. Now they choose which mode of delivery they want. Obesity, sedentary lifestyle again contributes to rise in C-section rate. When woman becomes pregnant after the treatment of secondary infertility, she is very apprehensive and she chooses cesarean section on demand. As far as cost factor is concerned, there are various insurance companies which provide you cashless facilities for C-section deliveries. Of course, for private health sector, cesarean section delivery takes less time and efforts and it pays definitely more than the effort and time you are spending in conducting a normal vaginal delivery. So what WHO is actually telling us, they have come out with these clinical recommendations for non-clinical interventions to reduce unnecessary cesarean section, and they came out with these guidelines in 2018. And these guidelines incorporates the views, fears, and beliefs of both women and health professionals about cesarean section. It also considers the complex dynamics and limitations of health systems and organizations and relationship between women, health professionals, and organization of healthcare services. So in nutshell, I will just tell you about the recommendations made by these guidelines. The first recommendation by WHO towards reducing C-section is health education for women is an essential component of antenatal care. The following educational interventions and support programs are recommended to reduce cesarean births. And what are these four components? Childbirth training workshops, nurses-led applied relaxation training programs, psychological couple-based preventive programs, and psychoeducation. Recommendation 2 is implementation of evidence-based clinical practice guidelines combined with structured mandatory second opinion for cesarean section indication. That is what they have recommended. That second opinion should be taken to reduce unnecessary C-sections in those settings who have got adequate resources and there are senior clinicians available to provide second opinion. So this is just a recommendation from WHO. Another recommendation from WHO is cesarean section audits and timely feedback to healthcare professionals are also recommended to reduce the C-section rate. According to this systematic review of qualitative studies, friends, still there is no clear consensus between healthcare professionals as to what constitutes a definite clinical indication for cesarean section. That is breech presentation, place, that is availability and access, or parity, woman with a previous cesarean section. By default, at most places, without giving a trial of scar, they are posted for elective C-section. The extent to which healthcare professionals value lowering the cesarean section rates locally is influenced by fear of blame and recrimination, including fear of litigation for not intervening. The value they attach to the personal financial reward associated with cesarean section. Any preference for cesarean as a convenient, efficient birth method that can be scheduled. Their beliefs about women, including shifts in beliefs about women's preparedness for labor and to give birth vaginally, among others. The third recommendation by WHO for the sole purpose of reducing C-section rate was collaborative midwifery obstetrician model of care. Again, they also recommended Financial strategies, physicians fee and vaginal births and cesarean sections. I know since so many years, there is Charcha amongst FOGSI and ICOG that the charges for cesarean and vaginal deliveries can be made similar to avoid this social stigma that doctors are doing cesareans just for financial incentives. Now this study is also, these points are based on these qualitative studies, and the findings indicate that some healthcare professionals are outspoken about the economic incentives for cesareans, particularly in private facilities. Some doctors considered cesareans to involve more work, which justified more payment, but others blamed the system, while others reported personally valuing the extra income. Dysfunctional teamwork within the medical profession and lack of communication are important barriers that need to be addressed in the context of fostering change and marginalization of across settings. But whenever we have any recommendations, there are always some challenges to implement these recommendations. So here in a nutshell, I am telling you the barriers or constraint towards these recommendation implementation. First is resistance of healthcare providers to changing their entrenched cesarean section practices, lack of understanding of the value of newly recommended interventions. Of course, for this, we all have to work very hard to increase the community level sensitization. Patients also make demands. We all know that C-section on demand is also rising. It is up to you how much importance should be given to this C-section on demand. Then at many private facilities, they are having space problems and thereby they cannot conduct the birth preparation classes or counseling sessions or the training workshops. So in these 5 recommendations, WHO has given a lot of importance to the audit, and that is why everyone is talking about this Robson classification. But whenever we are talking of Robson classification, do remember that it is a tool to judge the care rather than to recommend a care. Everyone is knowing these 3 groups of the Robson classification. Remember group 5, that is women with previous cesarean section, is the largest contributor to the total hospital cesarean rate. And thereby, we all have to work hard to prevent the primary cesarean section rate. The low risk groups, that is 1 to 4, is the second contributor to the overall C-section rates. And the lowest risk group, that is group 3, they have the lowest cesarean section rate. So therefore, every private and public facility should have regular C-section audit. Now, what this UNFPA report is telling us? The healthcare workers, they attribute growing number of cesarean sections to increasing organizational constraints. Everyone is pointing a finger at private health facilities, developing preventive and defensive medicines, and increase in the mindset of women about the fear of vaginal delivery, and they only come forward with the request for cesarean delivery. And this trend is rising, especially amongst the nulliparous women. Now, I would like to tell you about the FOGSI stand, because when there was a lot of hue and cry about this increased cesarean section rate, our FOGSI took a stand, and Dr. Jaideep Tank was the Secretary General of FOGSI, and he planned and came out with the FOGSI statement along with all our FOGSI presidents and all our advisors in the FOGSI. And let us look at the FOGSI statement. It says there is a surprising lack of clarity among various organizations on cesarean rates. It is altogether surprising that rhetoric is placed, sometimes even dangerously, what is best for the woman, her baby, and the family. The question which begs to be answered is therefore, is there a recommended rate for cesarean section? We all agree that the answer is no. When WHO came out with this statement, there is no justification for any reason to have cesarean section rates and WHO cannot have this cesarean section rates 10 to 15% for all over the world. Because there are many fallacies when this rate was declared that nobody should cross this threshold, and many factors were not taken into account. Not surprisingly, the WHO only issued a new statement in 2015 with the headline, "Every effort should be made to provide cesarean sections to women in need, rather than striving to achieve a specific rate." That is the statement given by WHO in 2015. This is the Indian data. This FOGSI statement is available on FOGSI website. You all can download and read in detail about the FOGSI statement on this cesarean section rate controversy which had arisen because of the WHO statement of a given threshold of 10 to 15%. So friends, the take-home message from my talk is that now WHO has changed their statement. They have said wherever it is indicated, it should be provided. But at the same time, WHO is telling us wherever possible, that is C-section rate should be tried and should be reduced in non-clinical indications. So thank you so much for your patient hearing. If there are any questions, please post in the chat box so that we can take all the questions at the end of the session.
Right. Thank you, Lakshmi. It was indeed an eye-opener, and it is really important for all of us to understand the current situation. About 4 years ago, as Secretary of the ICOG, I had an opportunity to participate in a meeting at the ICMR, and this was really a matter of concern because there was the State Health Secretary of Telangana, and few of the hospitals reported a C-section rate of almost 99%, which was really scary. So we, I think, have to reiterate that C-section has to be used judiciously, and we must make an effort to make every birth safe, and at the same time utilize our full skill and knowledge to deliver a patient vaginally. And of course, we should not, as WHO has very categorically said, deny C-section to a woman who needs it in reality. Ashok, may I ask you to make some comments, please?
Unmute, Ashok. Komal?
Yes,
Yeah.
ma'am, made post.
Yes. So thank you, Chairperson ICOG, Dr. Lakshmi Madam, for a very informative and very thought-provoking talk about reducing the cesarean rates. Yes, WHO has really highlighted these non-clinical intervention, and I may remind here there is a study, latest study which has been published from a private hospital of Delhi also, which is in the Indus Journal. They have also highlighted that it is not very difficult to reduce the cesarean rate in private setup also. And only they recommended some change in some practices, and they have shared their experience and what they have done over the last few years. And the practices, basically, as Madam has also highlighted, some practices has to be changed. The option of midwifery and the trained personnel should be there to hang on in the labor room and try to see how it is done. And obviously health education and awareness and counseling is very important component. So it is very important that all efforts should be made to reduce the cesarean rate. And as WHO has rightly told, that it is the outcome, optimum maternal and perinatal outcome is important. And obviously the cesarean rates will be different in different centers. You cannot have a uniform standard cesarean rates all over the country. So depending on the center or the health institute, the rates will be different, and they will be as per their needs and the requirement. And the main concern is the optimum outcome for the mother as well as for the baby. So with these guidelines and frameworks, obviously everyone is trying to now reduce the cesarean rates, and obviously the cornerstone must be the audit. And now most of the government initiated program and also the institutions are themselves are doing cesarean audits and trying to find out the facts to reduce the cesarean rates in future. With these words, thank you very much, Dr. Bharti Maheshwari, for giving us this opportunity and on Chai Pe Charcha. And thank you, Dr. Rishikesh Pai, President FOGSI, Secretary General Dr. Madhuri Patel, and Chairperson Dr. Lakshmi Shikande, and Vice Chair Dr. Parag Biniwala, and all our GC members and faculty and dear friends. So thank you very much.
Just one comment, if I may, do it. Now, 15% is something which I think all of us should do away with, because
Yes.
That is something which is really not practical. I'm sure there are so many seniors who managed medical colleges sitting here. We have Dr. Jyoti Bindal, Dr. Harish, and all. Before the meeting, I had a discussion with all HODs in the medical colleges of Pune, and in general, the C-section rate at that time was about 35 to 40%, which probably is high. But I think 15% is something which really has to look into.
Parag, you are absolutely right. And Bharti, we have started the ball rolling, and now you take it forward how we all can actually contribute towards reducing C-section rate.
Lakshmi, I would like to comment over here.
Yes,
The
Madhuri.
WHO has come out with a recent statement that you need not stick to 15% C-section
Yes,
rate.
that is what I have said.
Whenever a woman requires you how to do a C-section and not staff for that particular rate.
Yes, Dr. Harish Doshi wants to make a point.
Please unmute Dr. Harish Doshi.
इनको unmute करो कोमल, हरीश दोशी को.
I'll learn. Okay.
Done, ma'am.
Now,
Done, ma'am.
audible? Okay.
Yes.
The same thing that WHO 10 to 15%, and now the statement has changed. But this revised statement we should not take it in a way like liberalization of MTP Act. Everybody is eligible. So for everybody quoting this and then going for their own cesarean section rate. So that should not happen. The onus is on us, that is teachers in a medical college. 5 things I find, as Madam Lakshmi mentioned, primary cesarean section, oligo, cord round the neck in sonography, then no induction, so much increase without much clinical indication, no proper trial of labor, and thin meconium. These are all avoidable primary cesarean section. All 5 things which leads to increased cesarean section. Then after one cesarean section, people are not ready. So like you cannot force, but these things you can force. Oligo, see 3, 4 AFI, they go for cesarean section. Thin meconium, good FHS, cesarean section. Cord round the neck, sonography report, cesarean section. No proper trial of labor, cesarean section. And also increase induction. So primary cesarean section, as you stress, to be focused that these 5 indications should be very much screened. I, in my college, in my unit, always audit every single cesarean section, whether this could be prevented or not. Every cesarean, every cesarean, I used to check whether it can be prevented without maternal and perinatal morbidity. Then only something forcefully is to be done. Madam Dr. Bharti, please. So this is not a Chai Pe Charcha. This is a Charcha on a big scale.
No, you are absolutely right. But all said and done,
Harish, you are absolutely
double-edged
right,
sword,
yeah.
sir. Because on one hand, you are really under stress of litigation if something goes wrong. And on the other hand, I mean, we all have to try to reduce the C-section rate and without affecting the maternal and perinatal mortality and morbidity. So, and that is why we have brought out this discussion from ICOG. That is how we all can reduce C-section rate. So, Bharti, please take it forward.
Yes. So thank you very much, and very fruitful outcome by Dr. Lakshmi Madam and all chairpersons. So now we come to the next session, and we invite for a next panel Dr. Madhuri Patel Madam, that we all know that she is going to moderate the panel on the interpartum fetal monitoring, and then she has a parallels with her, none other than Dr. Doshi sir, and then Dr. Harish Doshi, yeah.
my patience waiting.
It is small. Yeah, we all know that he was the vice president of FOGSI. And Dr. Sarita Bhale Rao, madam, we all know that she's a governing council member as well as a joint secretary FOGSI, chair AICC RCOG West Zone. And then Dr. Professor Mala Srivastav, madam, she's a senior consultant, robotic surgeon at New Delhi, and Manoj Chalani, he's the director Ayush Hospital, Rescue Raipur. So with all these esteemed panelists, we are going to have a panel on the intrapartum monitoring with Dr. Madhuri Patel, madam. So, madam, please, you can start your share screen.
Bharti, thank you very much. And please let us know when we complete half an hour so we don't overshoot. Okay, Bharti. So, thank you very much, Lakshmi, Parag, Bharti, and Ashok Kumar and Rishikesh for giving us this opportunity. Can I share my screen? Hello.
Madam, you can share. You start.
1 minute, 1 minute, 1 minute. Can you see the screen?
Yes, we can see full screen. But need full screen.
Can you see my screen?
Yes, yes, madam.
Yes, ma'am.
One slideshow. I'll go to slideshow. Sorry, this is the office laptop I'm not used to. So I'm just sharing the. Okay. It's okay?
Yes, yes.
Yes. Thank you very much. And the topic is very, very interesting. Intrapartum fetal monitoring, what, when, and how. So this is what Dr. Harish Doshi has said, that how we will monitor, how we'll give the best to our babies, and at the same time, how we'll interpret and reduce the C-section rate. So if you see, we are already introduced Dr. Harish Doshi, Dr. Sarita, Dr. Mala, and Dr. Manoj. They are the excellent by professional, and two of them are teachers, and Sarita is of course at Vadia with me, and Manoj, and both of them are private practitioners. So let us see whether they differ or we continue with the same, intrapartum monitoring and outcome. So intrapartum fetal monitoring means careful observation of fetal behavior during labor. So it aims at the birth of a healthy baby with minimum intervention and to identify fetal hypoxia. The timely identification and rescue of the fetus at the risk of neonatal and long-term morbidity from intrapartum hypoxic insult. So I would like to ask our panelist, Dr. Harish Doshi, what are the different methods of monitoring of the fetus, and in intrapartum especially, which are the different?
The monitoring is for fetal monitoring, you want to say, or labor monitoring progress?
Labor monitoring, but can you highlight, antenatally what are the important things, and then immediately we switch over to labor?
No, antenatally or intrapartum, madam?
Okay, you start with intrapartum, okay?
Yes, intrapartum, right. We monitor as we know that partogram was long back, right? Introduced by WHO and revised, and present day partograph is there. But clinically, we assess naturally the three things: mother, baby, and progress of labor, right? And we are mainly concerned here with the fetus. Everybody knows how the mother is to be monitored with, right, vitals and other things. But for baby, in a first stage of labor, we auscultate fetal heart sound, intermittent fetal heart auscultation, right, every 15 minutes, maybe even with stethoscope, or you have a Doppler, or nowadays in a big institute, there are continuous monitoring is also there. So that we always, right, intermittent auscultation in a low risk patient is always accepted thing, evidence-based medicine. No need to go for, right, other simple intermittent auscultation. Continuous monitoring is not beneficial. Rather, sometimes it leads to more cesarean section that we are discussing now only. So that is there in a first stage of labor. Here you have mentioned in your slide 30 minutes, but okay, if it is good and if you can do it 15 minutes, but second stage of labor, always 5 minutes. So that you have categorized in low risk and high risk both way, but I would still suggest in a right, because some risk factors may not be properly assessed. First stage of labor 15 minutes and second stage of labor 5 minutes. But you are right, this is evidence-based medicine. So that is monitoring of the fetal heart sound. Then progress of labor monitoring, that is by per abdominal examination, as well as you mentioned, this right things for mother and all that. But then by per vaginal examination, right? Per vaginal examination, that is all things we see in our patients routinely, that starting from cervical dilatation, effacement, membranes, presenting part station, right? If the membranes are ruptured, if the membranes are ruptured, caput, molding, and pelvic assessment. This test you have mentioned, scalp, it is a very good test, right? Digital simulation, which gives right acceleration of fetal heart sound. Very simple test. Because we were teaching and discussing scalp blood pH, that we are not doing. So this is very simple test. When you touch it, the fetal head, some firmly, that it stimulates the fetal scalp, and then it leads to acceleration if fetus in a good healthy status. So that is you can also do during this right intrapartum monitoring. So mainly it is by progress of labor and fetal heart sound, low risk, intermittent, and high risk continuous monitoring every 30 and 15 minutes, every 5 minutes in the second stage of labor.
Thank you, Dr. Harish. Excellent. You have given that how you progress, how you monitor the progress of not only of the mother but also of the baby. Dr. Sarita, would you like to say something about this?
About the fetal scalp stimulation test. This is something which.
Yes.
No, this is something which we are not doing here. It is popular in England where they do it, and they check they put a fetal electrode and they actually check the CTG through the fetal scalp electrode.
Okay. Can I say something?
Not required.
Normally, when we have flat NST during labor, sometimes when we check.
Yeah, you have to unmute her.
Yeah.
Dr. Mala.
Sometimes when we have non-reactive NST or flat NST during labor, then we can do scalp stimulation and see whether everything is fine with the baby or not. When we are assessing dilatation, effacement, descent of the head, because if there is a flat NST, we have to reassess the patient. How far she has progressed into labor and what is the status of her vaginal findings. Then that time also we can do scalp.
You are muted, Dr. Maya.
If there is an acceleration, that reassures us that the baby is fine and we can continue with the vaginal delivery for her. Sometimes we make use of it.
Thank you, Dr. Mala. Sarita, would you comment on the STAN guidelines?
Yeah, so this also, the STAN guidelines are being used in UK, and this is for the fetal ECG waveform analysis, where they check the stress response of the fetus, and these guidelines have been put into practice in several countries, but here we are not using them.
Okay, for the postgraduate especially, we have put this slide. So what is it, how it is done? That's the reason, but in India, we are not doing so far. So now let us come to the indication. And about this, we were talking about the scalp pH. So we are not doing over here, but can you tell to our postgraduate that how you interpret this? Dr. Mala?
Yes.
Dr. Sarita, you continue.
No, so the fetal scalp blood is basically done, and if the scalp blood pH is more than 7.25 as this shows, then no action is necessary. If the pH is between 7.2 to 7.25, then we have to keep a watch, and it has to if the patient delivers quickly, that's fine, otherwise repeat it. And if the pH is less than 7.2, baby has to be delivered in the quickest possible way.
Thank you.
It is some guideline, yes.
So what are the indication of intrapartum fetal monitoring? Dr. Mala? All the patient we monitor intrapartum, right?
Yeah.
But there are specific where we have to pay high risk patients, we have to monitor very, very strictly, as Dr. Harish.
There are some maternal indications and there are some fetal indications for intrapartum fetal monitoring. Maternal indication, if the mother is having preeclampsia or eclampsia, gestational diabetes, or she's having APH, and we want her to have vaginal delivery, sometimes cardiac, anemic patients or renal disorders. And my fetal indications includes gross fetal growth restriction, prematurity, oligohydramnios, or abnormal umbilical artery Doppler, and sometimes if there is an ICOG immunization. Sometimes some things erupts during the labor itself. If there is excessive vaginal bleeding, or if there is a chorioamnitis, if we are giving Tolac, or there is an induced labor, or we are augmenting the labor, then in that case also we require continuous intrapartum monitoring. And if there is a meconium stain liquor, if it's a thin meconium and we think that everything is fine and she can deliver vaginally, then also she has to be kept under continuous fetal monitoring throughout the labor.
Dr. Harish Radoshi, I want to have one comment that when at the primigravida at 5 centimeter dilatation, we find it is a thin meconium stain liquor. So what message you will give? Whether you will do vaginal delivery or whether you will take for a C-section, everything is normal. We are doing ARM and we find a thin meconium stain liquor. Dr. Harish? I can't see Dr. Harish.
Yeah, he had to leave.
Any other panelists, Manoj, can you talk what you would like to do?
Ma'am, we'll monitor her, and then we'll see the progress, and we'll decide accordingly. If you have to go for vaginal, or then we have to convert it into the C-section.
Absolutely right, that because we are seeing a thin meconium at 5 centimeter, we cannot jump to take for a C-section. We have to monitor the patient as well as the baby, and accordingly we have to take the decision. So what are the causes of fetal hypoxia? Dr. Manoj?
Ma'am, it may be like maternal, antenatal maternal conditions may be there, like already discussed, diabetes or APH or
so Dr.
hypertension.
Mala has enumerated there. Yeah. Anything more than that?
Ma'am, during labor, there may be a previous C-section, or when we are inducing the labor, or there's augmentation of labor. And there are certain fetal conditions like meconium staining of amniotic fluid or post-emergency, post-term pregnancy is there.
Dr. Sarita, would you like to add something?
Yeah, so I think most of them have been said, maternal causes, fetal causes, and I think that vaginal bleeding in labor is something which is very sinister, and we have to, sometimes we think it is just show, but it may be, if it is more in amount, it could be, something sinister. Also, high-risk babies like IUGR babies, small for gestational age babies, those who had abnormal NST, those who have Doppler changes, these are the patients who are very likely to have intrapartum fetal distress.
So, Dr. Sarita, I would have one more question. You said about the intrauterine growth retardation. So, which baby you will ask for the vaginal, allow for the vaginal delivery, and which baby you will go for a C-section?
So I would basically see the situation, and there are multiple factors to see. If it is an IUGR baby and the weight is say between 2 and 2.5, it's an inducible cervix, she's likely to deliver quickly, and the NST is reactive, amniotic fluid is okay, the Doppler flow is not too bad, then I may attempt, or if she goes in labor on her own and she's progressing well, I will allow her to deliver. But if the baby is smaller than 2 kilos, if the Doppler flow is abnormal, if the liquor is less, if she's not inducible, then I don't think I would go for a long induction.
Excellent, Dr. Sarita, because severe IUGR with abnormality, other Doppler and all, we go for a section, but other
Hello?
and CTG. So I'm asking you, what are the NICE guidelines, FIGO guidelines, Who, any panelist can answer. Dr. Mala, would you like to answer?
Yeah, NICE guidelines, they say initial assessment should be done regarding the antenatal risk factors for fetal compromise, because there is a, whenever we take a patient into labor room, we do admission test. and we do admission tests and also risk assessment depending on the history, her antenatal parameters, whether she's a primigravida, high blood pressure, gestational diabetes, obesity, all these things have to be taken into account, as well as the admission test has to be done. This can stratify the patients into low risk category and high risk category. Of course, auscultation has to be done, and we have to carry, depending on the risk stratification of the patient, we have to decide whether this patient will have continuous monitoring or whether she will have intermittent monitoring. There is nothing for low risk category. Any low risk patient can become high risk during intramatum period. So we have to have a low threshold while monitoring the patients, and each patient in labor room has to be given due importance. Of course, when the patients have other comorbidities, they do become high risk categories, but every patient in labor deserves equal importance and need to be taken very seriously. Of course,
absolutely right. Dr. Manoj will come to now. You, how will you make decision based on the CTG stress?
Ma'am, if the CT is normal, then we'll continue to perform the risk assessment at least 1 hourly. And if there's a suspicion and there is no risk factor, then we'll continue the risk assessment. But if there's a suspicion if there's an interpartum risk factors, consider fetal scalp stimulation, and then we expedite the birth. And if it's pathological, then again we'll consider we'll look into the corrective methods if we can correct those things, and if it's normal. And if there's still pathological after implementing corrective measures, then we will have the urgent, we will try to intervene and progress accordingly.
Great. Dr. Sarita, are there any difference in the FIGO guidelines, ICOG or ACOG? There are different guidelines, intrapartum monitoring. So what you would like to tell us? Dr. Sarita? Is Dr. Sarita around? Dr. Mala, you can.
Yeah, I'm here.
Yeah. Dr. Sarita, we have a different guidelines like FIGO, ICOG, ICOG and all during intrapartum monitoring. So are they different or they are almost the same? And what way they differ?
So I think that what I've been following is exactly what you've put up, the revised FIGO guidelines, where we look at normal, suspicious, and pathological, and we look at variability, decelerations as the most important thing. And if the variability is between 120 to 160 or 110 to 150 as put up, if the baseline is 110 to 150, variability is 5 to 25 with no decelerations, that is normal. And suspicious will be if it is lacking in one of the characteristics but no pathological features. And pathological is if there is reduced baseline below 100, reduced variability or decelerations.
Great. So more or less, what Dr. Sarita pointed out, that we go for the FIGO, but anybody would differ, Dr. Mala or Manoj, would like to have a feature, or this is a RCOG recommendation. It is more or less same, right?
We all are following FIGO guidelines.
Skip this. Now, Dr. Mala has already talked about the admission test, right? So admission test is done that at the time of when the patient gets admitted, what is the fetal condition, whether fetus has a problem, or then we can monitor accordingly if it does not have a problem. But what is the role of admission test in today's scenario? Anybody would like to answer?
Yes, I think admission test is very important because the admission test does give you, some idea that this patient, if it is a good normal admission test, that the patient is likely to have a good outcome in labor or not develop fetal distress immediately. But if at admission, if the antenatal CTG is not good, then I think that it definitely tells us that this patient may not go through, baby may not withstand the stress of labor.
Okay, great. So admission test does have a role in today's scenario. And once the admission test is normal, patient is not on the continuous monitoring, how often you will advise for CTG? Dr. Sarita?
So
Low risk
again,
patient,
it
high risk patient, of course, we will continuously monitor, but we don't have facility.
no, so if it is a low risk patient, again, it depends. If the patient is in early labor or the patient once she's in active labor, depending on that, I think intermittent auscultation is also quite all right if you have a good admission test. And maybe you may want to repeat the CTG when the patient is on oxytocin or once 4-5 hours have passed.
So Dr. Mala and Dr. Manoj, your comments?
Yes, ma'am,
Madam
true.
is
Once
right
we have
that
done the admission test, then we are reassured, and auscultation is quite good enough.
So we'll go to the next. This is an antenatal, CTG normal. Dr. Manoj, would you like to explain this? We are into antenatal.
Yeah. See, we have
Yes, ma'am.
taken
So the
four
baseline
parameters.
heart rate is between 100 and 160, ma'am, and the variability of FHR is between 5 to 25 beats per minute, and the distillations are absent or early, and if it's in suspicion, there's a lacking at least one characteristic of normality, but no pathological features are there. And in pathological, there is a reduced variability, there's an increased variability, there's a sinusoidal pattern is there, and the deceleration is more than 5 minutes, and there's a high probability of hypoxia or acidosis in this case.
Good. So let us look at this, tracing. Dr. Mala, would you like to comment on this tracing?
See, the tracing on the upper left side, this has a beat to beat variability is normal. Though we do not find very good acceleration, but baseline is between 110 to 120. So baseline is all right, but though there is not very good accelerations, but beat to beat variability is fair enough. So this can be a suspicious pattern, but lower down left side is sinusoidal pattern. It is very suspicious, and when there is a sinusoidal pattern, the baby has to be delivered immediately. On the right side, there is almost a flat NST with reduced variability. There is no acceleration, and of course, there is no deceleration as well. This is also a suspicious graph for the patient.
So how will you manage this case?
Depending on her other parameters, whether she's the primary gravida, second gravida, whether she has had a previous normal delivery, what is the PV finding, whether she's going to deliver within half an hour or 1 hour, what is the dilatation of the cervix, whether the effacement of the cervix, whether the liquor is clear or not, of the presenting part. Taking everything into account, we can keep her into continuous monitoring. If we think that the patient can have a safe vaginal delivery, then we can allow for vaginal delivery. But because there is no role of difficult vaginal delivery in modern obstetrics, we have to ensure that both the mother and the baby are fine at the end of the labor. So depending on all the parameters, maternal factors and fetal factors, we have to take a call. This is a suspicious NST. Of course, sinusoidal means immediate delivery. If she's almost 9 centimeters, almost about to deliver, we can deliver her vaginally. Otherwise, we'll have to take her up for cesarean section.
Thank you. Thank you, Dr. Mala. We'll go forward. And here, Dr. Manoj, can you explain? Is Dr. Haresh around now? No, no? Then Manoj, you can speak on this slide.
Yeah, ma'am. So here we can see, ma'am, that there's we see the heart rates, that there's a minimal early deceleration is there, then we can see the late deceleration, and there's a variable deceleration is seen. So one is type 1, the another one is type 2. So the principal cause of first one is head compression. Second, you see it's just because of placental insufficiency there, which is leading to the late deceleration. And the variable deceleration may be because of umbilical cord compression.
Yes, so I want to give a clear message that due to head compression, early decelerations are there. You need not worry. But other late deceleration, we have to, it shows the uteroplacental insufficiency. So we have to worry. And of course, umbilical cord, because I have seen when the variable deceleration occurs, many people take for C-section. So we have to change the position of the patient and see. So there are certain, this type of deceleration whether you have to observe or you have to take, that decision is yours. But these are the early deceleration and this is variable deceleration. You can go ahead, wait and watch. So now, correct method of, if Dr. Bharti, time is over, please let us know. We have already talked about this. So we will go, the time is, I think, getting over. So what are the abnormal findings of CTG needs cesarean section now? Exactly, we are coming, any of the panelists can answer.
Ma'am, it is a bradycardia which is less than 100 beats per minute, or the tachycardia which is 160, more than 160 beats for more than 60 minutes is there, or there's a late deceleration is there, or there's no acceleration, or when there's a atypical variable acceleration is there. So in these cases, we will go for cesarean section.
Dr. Sarita, would you like to say something?
No, I think Dr. Manoj has given us all the situations in which emergency cesarean is necessary. And I think it's very well explained on the slide also.
Dr. Mala?
Yeah.
You have already covered by reading the NST, CTG. Yeah. So anything more you would like to add?
See, basically, Dr. Manoj has highlighted everything. But if there is a late deceleration or there is a prolonged deceleration, then in that case also we have to take a quick decision about the mode of delivery. Unless the patient is going to deliver with full dilatation, otherwise we'll have to take a call for the patient for cesarean section.
Okay. So our last slide is take home message from each panelist. Sarita, we'll start with you.
Yeah, so I think that intrapartum fetal monitoring is a very, very helpful and an important modality, and monitoring, whether it is intermittent auscultation or it is electronic fetal heart monitoring. I think every obstetrician has to, master this technique.
Good. Dr. Manoj?
I feel that, I feel that meconium staining of amniotic fluid is not very accurate, it's not very reliable. So we should go for CTG, and we should keep close monitoring of the fetus before we decide on the outcome. Just on the basis of meconium, we should not make this.
Okay. Yeah, Dr. Mala?
When we know a patient is a low risk or high risk, we have to have a low threshold, especially in the high risk patients. We have to have low threshold for a safe delivery for both the mother as well as the fetus. In this, intrapartum fetal monitoring, maybe continuous fetal monitoring will help us really. And any sign of fetal distress should be taken seriously. And if the patient is about to deliver very soon, then and only she should be left for vaginal delivery. Otherwise, we should not hesitate to take up our patients for cesarean section. Because at the end of every labor, mother and child safety. Very important.
Great. But see, and one more message we have to give, that electronic fetal monitoring, with the slightest changes also we take patient for a C-section. So we have to see the monitoring is done properly, interpretation is done properly. So this is one of the other reasons where we can reduce the C-section rate. And of course, with the variable deceleration, we can have a amnio infusion and we can, reduce the variable deceleration. So this is one more thing where we can reduce the C-section. So excellent. The team has performed, Dr. Sarita, Dr. Haresh Joshi, Dr. Mala and Manoj. Excellent work, excellent explanation have been done. And I hope our delegates and the other professors, they are there, they have joined, from the colleges and the consultants, senior consultant. I hope we have given the message properly. And thank you very much, Dr. Lakshmi. On behalf of my panelists and myself, I thank Dr. Lakshmi and the team and Dr. Rishikesh and team for giving us this opportunity. And of course, I cannot forget Bharti. Bharti, thank you very much.
Thank you. Thank you, madam. Wonderful discussion. Please stop, share your screen. Yeah,
Yes.
so
Thank you, ma'am. Thank you very much.
Thanks, madam, for an excellent opportunity.
Yeah, in limited time, you have covered many things. So that is the very good, fruitful discussions. And then without doing any delay, we come to the next session, and that is another panel discussion, and moderator is none other than Dr. Ashish Kumar Mukhopadhyay, and they are and he with his team are going to have a panel on operative vaginal delivery. And panelist is Dr. Alka Pandey. We all know that he is the Vice President FOGSI nowadays and Professor Department of Obs and Gynae, Narayan Medical College, Saharsa. Then Dr. Abharani Shira, Professor Obs and Gynae, SKMC Muzaffarpur, and ex-Youth Quiz Committee Chairperson. Dr. Kiran Pandey, Madam, she is a Chairperson Medical Education Committee at present, and she is from Kanpur. We all know her. And then Dr. Shobha Gudi, Madam, that she is the President BS Bangalore Obs and Gynae Society, Chairperson Family Welfare Committee. So welcome all panelists and moderators, and now session is for you for 30 minutes. Next, Dr. Ashish sir, please share your screen.
Good evening, everyone.
देख नहीं रहे आशीष जी, अभी तो थे.
है डॉक्टर आशीष इज देयर. डॉक्टर आशीष अनम्यूट कीजिए अपने आप को. डॉक्टर आशीष अनम्यूट. डॉक्टर भारती, डॉक्टर आशीष is messaging कि host is not allowing to unmute. Please देखिए.
I am calling her. If he is not respond, then we start.
Okay.
Ashish sir,
Not allowed to unmute. So those three inevitable questions in a panel, in a webinar. Am I visible?
Yes.
Yes.
Am I audible?
Yes.
Yes.
Third question will come in a second. Are my slides visible?
No.
It will come in a minute. Now are the slides visible now?
Yes, sir. Please make it a full screen.
Thank you so much,
Yeah,
madam.
visible. Yeah.
And what a pleasure joining in a panel which is being contributed by four giants of obstetrics. Dr. Abharani Sinha, Dr. Alka Pandey, Dr. Kiran Pandey, and Dr. Shobha Gudi. Four gems of obstetrics. I'm very lucky to have them. And thanks to Aarti, because she has managed to get them all together in a half an hour panel. By the way, this is the first time I am conducting a panel of 29 minutes, 59 seconds, and therefore I am nervous. I have some disclaimer in this panel from the very beginning that I will not cover many things in 29 minutes, 59 seconds panel. The first thing is that I will not go into detailed discussion of any technique, because these GM obstetricians, they know everything, and I suppose that the audience is too august to know all these things, to have ignorance of all these things. Secondly, I will not discuss the destructive operations, complex manipulations, and the forceps or instruments which are obsolete now, that is killings. So that is my disclaimer. With that, because I may be excused, if you someday give another half an hour, I will discuss. So I will invite Dr. Alka Pandey at the very beginning of the panel discussion. Madam, what are the indications you find where operative vaginal delivery can be done today? Madam Dr. Alka Pandey.
Thank you, sir. In cases of maternal distress, where the labor is prolonged in spite of expulsive efforts, then to cut short the second stage of labor in certain conditions such as heart disease, eclampsia, severe degree of anemia, cerebrovascular problems, spinal injuries. So where we want to cut short the second stage, and then fetal distress. And fetal distress and low birth babies and forceps we can apply in after coming head of the fetus.
So there are special situations. But most importantly, madam, I would like to ask you and other panelists also that to cut short the second stage of labor, do you still apply forceps even today? If so, what are the indications? What are the conditions? I think nowadays we have reduced the indications of cutting short the second stage of labor.
In heart disease, sir, in heart disease, we want to cut short. So if the labor is being prolonged, we would like to cut short.
Okay. So not in all cases, but in cases where the expulsive effort of the mother or Valsalva are to be avoided, which will cause more damage to the heart or the circulation. Okay. Now we talked about fetal distress. What are the features of presumed fetal jeopardy? One is a non-reassuring fetal heart. I think it has been discussed pretty well by Madhuri in the previous panel. Bradycardia, lead decelerations, and rapid fetal heart more than 160 beats per minute. Is it of concern, madam? Dr. Alka Pandey, is it of concern when the fetal heart rate goes beyond 160 beats per minute? In other words, what are the things?
It has to be persistently high, sir.
Yeah. Or do you exclude some other conditions, maternal conditions?
Yes, if the mother is having fever, if she is having anemia, so in these conditions, the fetal heart rate can be high.
And maternal tachycardia also. If maternal tachycardia is there, then usually it is associated with fetal tachycardia.
Actually,
Right.
in fever, there is maternal tachycardia.
Fever largely
and
includes
anemia.
that. But we have discussed a lot about the passage of meconium. Do you all agree with the previous panel's discussion on the meconium? Or you take a more liberal view on the meconium? As soon as the meconium
if it is thin, we can wait. If it is thick, we have to expedite.
Okay, we talked about low birth weight baby. And once upon a time, we used to see low birth weight baby is a contraindication of instrumental vaginal delivery. What is your opinion on this, madam?
So, sir, if it is preterm, it has always been said that if you apply forceps, it works like a protective cage. So, it can be applied in preterm babies, and in IUGR also it can be applied.
I'll bring in Dr. Kiran Pandey here. See, there are a lot of studies which have proved beyond doubt that the so-called protective cage doesn't work. You know, so does it hold still true? Or would you like to have a revised opinion about the low birth weight babies, particularly the preterm babies?
Thank you, Dr. Ashish, for asking this question. You are very right. Actually, to be honest, this indication of giving forceps to low birth babies has been more of a theoretically. We practically, low birth weight babies, if they're very small, they usually come out with a slight, even the moderate expulsive efforts also without much of the things. So we always avoid it. Secondly, there is always you have to be very careful. The head is not well fitting into the forceps until you have designed a different forceps according to the size. Otherwise, it is not well fitting. So that doesn't hold true, as you said in the studies. And therefore, practically speaking, we do not give this forceps. And of course, ventus, etc., you cannot give. It was only forceps which was told. No other instrumental delivery is.
Only for forceps, the protective cage theory was valid for quite some time. But now we have observed, these are also our personal experience. We are all doing obstetrics left and right. We have also observed that a slight bit of tilt of the forceps blade to a premature baby's head will cause a havoc damage because the bones are quite soft. You know, so that's why I am very concerned about the preterm babies being applied forceps. Okay, so we will leave it at that because the things vary. Whenever the instruments are there, the users vary, the indications vary, etc., etc. Now I will go into the battery of 4 case scenarios to each of the panelists. First to Dr. Shobha. So, Dr. Shobha, you are here. Dr. Shobha Goody, is she there?
Dr. Shobha is there. She wanted to be unmuted. I think
once again,
she had requested to be made.
Bharti, you are adding my time.
Yes, sir, definitely. Shobha, madam. Very interesting panel. I want to.
Yeah, now I am unmuted.
Madam, yes, you are audible now.
Thank you, madam.
Yeah.
It's a pleasure hearing your voice.
Yeah, sir. Same, likewise. It's a pleasure hearing your voice also.
But 2 minutes I added to my time because you took time to unmute yourself.
No, that's not my fault, right? So they have to give us
I am telling this to Bharti.
Yes, sir, added.
You please tell the case, otherwise we'll lose.
Yes, young primary gravida, uncomplicated pregnancy, presence with prolonged second stage of labor, average size baby, adequate pelvis. She underwent trial of vaginal delivery with a reasonably good progress in first stage of labor. All good. In second stage, however, she presents with a PV finding of os fully dilated, cervix taken up, but no descent for half an hour, station stuck at +1. What are your management options from this point?
Yes, sir. Yes, sir. So I just wanted to know, sir, why is it put as trial of vaginal delivery? इसमें क्यों ऐसा है? Because she is a primary gravida, so average size adequate pelvis.
Okay. So please put the answer on hold.
So I think
when I deliver the second case scenario to the second panelist, just think about the answer. We'll come back, or would you like to finish it now?
We'll finish it now.
Okay.
So in the second stage, we need to know how long. It is only mentioned prolonged, but we are not told the time. So usually in primaries, we feel
half an hour.
It's a half an hour written.
Okay, it is there. Okay. It is for half an hour, and station is taken up, but no descent, half an hour. So no descent for half an hour. Station is at +1. The cervix is fully dilated also for half an hour only. That is my presumption here. So actually right now, looking at this, the only thing we need to ensure is if the bladder is empty and whether she is getting good uterine contractions. Because there is no sign of any caput or molding. And also I would like to know one more detail is how much of FOGSI is palpable per abdomen. Is the head completely gone into the pelvis? So I need to know that, and I need to know how are the uterine contractions. I would like to optimize that. If it is not kind of good, then I would like to start at this point of time 5 units of oxytocin in maybe no normal saline, and we want to give her at least 30 to 40 drops per minute in order for her to get good pains. If that is assured, then I think we can still wait for the station to come to +2 and then see if her pushing efforts will deliver her or else. So there is a scope of waiting in this case for at least another half an hour, provided the mother's condition and the fetal condition is perfect. So
thank you, Shubhadi. Thank you. And the present WHO guidelines, labor care guidelines, they would like you to wait longer for a longer period of life. Anyhow, I like the way you approach the case because you opened your gloves after the PV examination and went for the abdominal examination. That's marvelous. Because unless and until you see it para-abdominally, seeing the number of FIPS, this is the mistake which most of the juniors will make, that they will try to assess the descent through the vaginal fingers, which is defective. So I am very happy at that, and 10 on 10 to you for this. And thank you very much, Dr. Shobha Goody. I'll go to the next case. A 28 years post-cesarean section pregnancy with the last childbirth 3 years ago was put up for VBAC and was successfully conducted in a teaching institute. Do you recommend prophylactic application of forceps in this case or not? The patient doesn't have heart disease. She is not suffering from severe anemia, but she is undergoing VBAC and quite successfully done up to the end point. Now the second stage has come. Would you like to recommend prophylactic forceps here? Dr. Abha Ranisina, madam.
Sir, so not routinely, sir. If the patient is progressing well and if it is descended, I can just offer her an outlet forceps. Otherwise, not a low cavity forceps or a mid cavity forceps.
Okay, fine. Thank you so much, madam. I got your answer. Third case to Dr.
Shobha Goody.
Oh, it is once again to Dr. Shobha Goody. Yes.
You don't want to give it to me?
No, I think it is Dr. Kiran Pandey. Yes.
Okay,
23 years. 23 years, primary gravida, rheumatic heart disease, New York Heart Association grade 2, went in spontaneous labor and progressed smoothly. Will routine forceps application in second stage help her? And which instrument would you prefer if you like to use forceps here? Dr. Pandey.
Should I answer?
Yeah. No, madam. First, Dr. Kiran Pandey.
You can give answer because the next case has been mentioned for me. So whatever you feel like, Dr. Ashish, whatever you say.
Yeah.
Okay.
So
Dr. Shobha Goody.
yeah, the first thing I would like is to check on the mother. Because this looks like the fetus is not having any problem, but since she is a case of cardiac disease NYHA grade 2, I want to make sure that in labor she has not progressed beyond that grading. There is always a chance that there is progress of heart disease in the early third trimester, during labor and immediately after labor. We all know that. So for that reason, I would like to check her status, and if I find that there is no tachycardia, there is no features of heart failure like crepitations, etc., or even tachypnea, then I will see. I would like to avoid any interference. I would like to avoid intervention because she is grade 2 and she will be able to bear down. If we feel that she is not able to, because it is a little more than only her routine effort maybe. So if she is becoming breathless, then definitely I will help her out. But probably, yes, forceps application rather than vacuum will help.
What kind of monitoring in the second stage do you rely upon? Is it a usual clinical monitoring, or you need?
No, I would need a pulse oximeter for her.
Okay.
I would need a pulse oximeter, and I would have informed the physician or the cardiologist in charge. At least if they cannot be present, at least a resident could be present. I would like to manage her heart failure if it happens very expeditiously. So I want another help there. And also because I'll be doing this and my resident will be helping me. So I want one more help. That is for sure. But
that
yes,
is a human resource helping.
Yeah.
No, do you need a
forceps application will help some women with cardiac illness. There is no doubt. Yeah.
Okay.
But we have to kind of not add instrumentation into this thing already existing problem, because she may bleed more because of that. She may develop infection. She may have more problems. So better to avoid unless it is very necessary. There is no role for routine forceps application. Yeah.
Fine. Madam, I am coming to you, Dr. Kiran Pandey. As you said, the next case is yours. You booked it. 22 years in labor, was admitted with repeated convulsions in the early hours of the day. Labor progressed smoothly, but and convulsion eventually controlled with Maxelf. Do you perform 0-hour C-section in cases of eclampsia in your institution? And do you routinely apply instruments at second stage of labor in eclampsia? The first question is, do you perform 0-hour C-section in cases of eclampsia, which was once upon a time very, very popular?
Thank you, Dr. Ashish. Basically, as we all know, with the improvement in the management of the convulsive eclampsia and the adequate monitoring and the facilities for manage the complications of anesthesia, now it is not that strategy that as soon as the patient comes 0-hour cesarean section. In fact, it's always said, at least for a long time, that once the convulsions are controlled, evaluate the patient per-abdominally, do the Bishop scoring. Can you induce it? And but of course, you have to see that the convulsions have stopped at least for 4 hours, and then you can even induce her if the Bishop score is more than 6, pelvis is adequate, maternal condition is stable, and the fetal heart is okay. Then we can go ahead with this. If in those cases where in spite of your regime which you are using, Pritchard or Zucker, whatever anticonvulsant regime you are using, either the maternal condition is deteriorating or the convulsions are not controlled or the fetal heart is getting affected, in all those cases, you can, or the patient is suffering with any complications, the other complications of it, lending like urine output is decreased or some other, the liver enzymes are being affected, or the cerebral edema signs are coming, in those cases, you will have to take her for immediate cesarean section. Otherwise, we do give trial. It has been very successfully seen in these cases. Labor can be induced without any complications.
So in other words, you're not
As far as
preferring 0-hour C-section these days. Okay.
Yeah.
I get your point.
Yeah.
Now,
And the second thing is, do you apply?
I'll just shoot this question to Dr. Abha Ranisina, madam. If you agree to these instruments at second stage of labor in eclampsia, which instrument, which forceps would you like to prefer?
So that will depend upon the level of the, usually it is a low cavity forceps, because in these patients, outlet forceps are what, in my clinical experience, what I've seen, it's usually the low cavity forceps which we have to apply.
Okay. So, no, you said it depends on the level of the head. That's true. But in these, today, do you like to apply a mid cavity forceps or low mid cavity forceps? You will wait for the, or you will wait for the head to come down. If it doesn't, you won't apply the forceps. That's what my question is.
Definitely, sir. I like the head to come down. I mean, usually we do not apply the mid cavity forceps. We prefer the head to come down. It's better to do a mid cavity if it is stuck at the mid cavity, to do a C-section rather than go for a low cavity. That is my experience, and that is what I do, sir.
Okay. So today, for all practical purposes, the high mid forceps and the low mid forceps, they are almost gone. And today we are mostly using the low forceps and the outlet.
Yes, sir.
Only these two.
Yes, sir.
I think that is for the betterment of the patient, because we have seen many catastrophes with the use of the even low mid forceps. So we have almost abandoned them. So what are the prerequisites for forceps? Well, everyone knows them, but just mention in order of your preference, which one would you prefer most? The prerequisites.
First of all, we have to do a proper and vaginal examination, as you have rightly mentioned, that we have to do an abdominal examination, and if the head is, it's preferable that none of the pores are palpable, but we can apply forceps if it is 1/5 palpable. And again, we have to see that there is no contracted pelvis. The membranes are ruptured. I think that is for a postgraduate or for a clinician, that is not an important point. The bladder should be emptied, and if there is a catheter in situ, then the bulb should be deflated. And of course, we have to see the position. Seeing the position is very important, that how much is the rotation and where is the station. I think that is very, very important. And there should be no outlet contraction. And the features, the size of the features is also very important. There should be no cephalopelvic disproportion. But cephalopelvic disproportion is usually with the brim. So when we are talking about forceps, they have to see the outlet.
Is living baby a prerequisite for forceps, Dr. Shobha Gudi, madam?
Please come again with the question. Sorry, sir.
Is prerequisite for the forceps, one of the prerequisites of the forceps, is it a living baby? Do you need a living baby to apply forceps?
No, even for intrauterine demise, it can be applied. It's not like that. But I just wanted to mention one thing here, that we do not use instrumental delivery in modern obstetrics if any fifth of the head is palpable.
Yeah, you have mentioned that.
Totally not palpable per abdomen.
Thank you for repeating this, but humko acha laga ke you are doing something for the dead babies at least. Nobody is doing something. Medical legal, any medical
only
legal
if it is
aspect?
indicated, yeah.
Yes. Only any medical legal aspect that you can remember in forceps application, your past experience or your apprehension or your fear.
Oh, yes. Oh, plenty.
Dr. Alka Pandey, I would like to bring her here.
Yes.
Dr. Alka Pandey. Yes, madam.
Yes, sir.
Yeah, any medical legal aspects that you have faced regarding the forceps, which has rather made you concerned or about, accept this thing about forceps, scary about forceps that has happened?
Yes, sir. Deafness.
Okay. Deafness.
So,
can I answer that question?
Bell's palsy, sir. Bell's palsy.
Dr. Pai sir has
I wanted to say Bell's palsy.
Actually, Dr. Pai sir has joined and he has to board. So he has to address for a few minutes. If it is then we can wait.
Yeah, I would like to answer more on this, Dr.
Yeah, you just answer.
After Dr. Pai.
Yeah. After Dr. Pai.
Thank you, all of you. I mean, I was actually at comment, but one of the topmost journalists in Bombay phoned me and asked me about cesarean section just now. So he had done public PIL or whatever, not PIL, he had done what is that, uh, right to RTI, and the section rate in Mumbai is 36%. So he was asking me about that just now only. As you were, I came in and he phoned me. So I was telling him, and that's the same thing I will tell you. So basically, there are 2-3 things that are happening at the same time. The government is after our blood to bring down the section rate. The section rate has tended to go up. NHFI survey has shown 22%, 21.5 or something. Section rate in the NHFI survey number 5. And overall section rates have gone up a little. So I told him, and this is what I want to tell. I said, we have already had a meeting in the Federation, and we have decided to do the modification of Robson's criteria. Because there are certain things that are there in India, like previous precious child, etc., and cesarean on demand that are not there in the roster. So our group is doing the modification. Once the modification is done, we are going to have an analysis of what is happening in our country. So because the Manyata nursing homes are having good standards, at least we think that they are having good standards because they have been trained, and 1,800 of them are there. We will identify some of the best ones by talking to our local presidents, and once they are identified, we'll start collecting the data from those nursing homes. Once those data is collected, we'll come to know what is, and we'll classify it. And during Rishma's tenure as president, I had also done a cesarean section meeting. I was that time the Secretary General. And we had also done a beautiful classification, not on Robson, but on algorithm and indication. So we'll combine these classifications, and then we are going to talk to the UNICEF people. I must tell you that Dr. Madhuri Patel, our Secretary General, is also very active in this. And all our team is active. So we will talk to the UNICEF people. They have already created the Mantra app for the Uttar Pradesh government. So that app will be utilized, and we will start routing the data through that app, and we will do voluntary collection of the data. Once that data is done, then we'll come to know actually what would be an ideal section rate for each of the groups which we have created with the modifications. At the same time, I've also told them that don't change the Robson criteria because government is very rigid. So if you do something different, so we'll have the Robson criteria and the additional modification as a separate group, so that we will have this data collection. Once that data collection is done, we will be able to set the section rate. Of course, our stand is that there is no definitive number of the section rate because every individual is a different person. This is the second thing which I know what is the conversation that is going on is see now, I was listening to all of you. I normally don't do obstetrics, but each one of you does everything differently. So one of my responsibilities as the FOGSI president and the person who doesn't do active obstetrics is to get all of you together and let us sit together and decide once and for all, for God's sake, that if a patient comes into the labor room, how all of you will manage them in the same way. This is the biggest problem. The biggest problem with all of us is that we are differently managing them. There has to be the protocol that has to be not deviated at all. हमारे IVF में तो standard protocol है. Why can't there be a standard protocol in labor? One professor will say something else, another professor will say something else. One professor will say, I will classify the patient as soon as they come to labor. What is this? Why can't you all have the same protocol? You all sit together. I'm going to call all the 30 state presidents and all the 260, you all sit together, and all the big professors. You come together, go to Goa for 5 days and sit together and come out with a standardized protocol. Once and for all. Because what is happening, some medical college somewhere in some state will teach their children like this, someone will teach like that. After that, they'll come out and they will have different protocols. Then they will come to FOGSI and get Manyata training done. Why can't this all be done at the beginning when they are in the first house post? What is the problem? Why are you having difference in, why each of you professors is having difference in training? Why can't all you be in the same page? So we must now do it. We have to do it. I'm not going to, otherwise I'm not going to leave the FOGSI presidency. I will not give it to Jaideep Tang. I'll say I'm not going to leave unless you all come together, and this is our most important one of the biggest important presidential initiative is promotion of respectful and safe vaginal birth, not decreasing section rate. No, respectful and safe vaginal birth with decrease in mortality as well as morbidity in the mother and the child. This is our objective. So, and other thing, the last thing is same charges. Let's sit down together. Section rate and delivery rate charges should be same at different level. Maybe you are having a simple nursing home, you may charge 20,000. You may have a fancy nursing home, you may charge 50,000. You may have a corporate where you may charge 3 lakh. But for God's sake, you have the same rate of the procedure. So you can divide the charges into procedure charges, and you can have the, suppose cesarean rate, actual surgeon charges should be the same as the normal delivery charges. Then you can add the OT charges, anesthesia charges, suture material, all that differently. But this rate has to be, the charges have to be the same. So I think that, and the fourth thing we have to do is that I'm going to have TOTs. Every society is going to have it. And during that TOT, see, the problem is not that we are doing something wrong. It is the society's perception that we are doing something wrong. And the only way to dispel this perception is by getting them into confidence. So whenever we are going to have the TOT, we are going to call the government official. We'll say, you please come. Give 10-minute talk to our people also. So you are satisfied. We can give, we have to join hands, because the perception is that we are doing wrong thing. It is not that they are doing wrong thing. They think that we are doing wrong. And we have to also safeguard against our black sheep. There are always black sheep in every profession. So we have to safeguard and see that if there is a black sheep who does unnecessary section, we have to outcast that person, because they are spoiling our reputation. So we have to collectively do this together. And this is my chai pe charcha for you. You think about it. This is my priority. I'm thankful to Lakshmi. I had got sidetracked with the yatra and all that. But this is in my mind priority. And I am not going to leave the FOGSI president's post unless you all do it for me. And this is the year when we are going to do it once and for all. We are going to do it. Let us all pledge that we are going to do it once and for all.
Sir.
Thank you.
Yes, thank you, Dr. Pai.
Yes.
Thank you.
Thank you, sir.
Definitely, Dr. Rishi.
We will decide on the charges at Goa.
Yeah.
Yeah.
Thank you.
Thank you.
Thank you so much.
Thank you, sir.
Impulsive, strongly emotionally charged lecture. I appreciate this.
Yes, yes, very fruitful.
We have to translate this into action. If we have the algorithm, there was a meeting. I come to know that was a meeting where they are saying that there is a variegation of the treatment protocol. So that we have got a lot of big people like Dr. Jindal. I can see all big shot. Dr. Bindal is there. Dr. Ranjana Khanna is there. All big shot professors are there. So all of you, Dr. Ashish Mukhopadhyay, Dr. Lakshmi, Dr. Madhuri, so many big shots. So we have to all sit together and one by one अपन ना एक protocol बना देंगे. FOGSI का book ही बना देंगे. Obstetric का बड़ा नहीं book. एक Obstetric का handbook बना देते हैं. वो Bible हमारा. सबको हम वो बना के सबको सर्कुलेट करेंगे. एम्स का प्रोफेसर को देंगे, सफदरजंग के प्रोफेसर को देंगे, मणिपाल के प्रोफेसर को देंगे, MP के प्रोफेसर को देंगे. बिकॉज प्रोफेसर सी हमारे देश में ये सबसे इम्पोर्टेंट भाव प्रोफेसर को मिलता है. प्रोफेसर जो बोलता है वो सच है. बाकी डॉक्टर पाई भी तो चलो फालतू, तो कोई FOGSI प्रेसिडेंट है उससे तो ठीक है, डजंट मैटर. प्रोफेसर हमारी है ना FOGSI मेंबर, उनके जरिए हमको एक फाइनल WHO यूनिसेफ जो कुछ भी एक डॉक्यूमेंट आप बनाओ कि कौन सा डॉक्यूमेंट जो है वो ये जो लक्ष्य का डॉक्यूमेंट है ना वो अच्छा डॉक्यूमेंट है. बिकॉज दैट्स अ गवर्नमेंट डॉक्यूमेंट. उससे जो कुछ भी हम डिराइव कर सकते हैं प्रोफेसर की मदद से, हम अच्छा एक फाइनल एल्गोरिदम बना देंगे. एक हम लोग वीडियो कंसेंट भी बना देंगे हिंदी में और अरब लैंग्वेजेस में. सो पेशेंट को सिजरियन देना है तो वो कंसेंट प्ले कर सकते हैं, उनको सब इंफॉर्मेशन दे सकते हैं. उसमें वो हम लोग वेट करेंगे. गवर्नमेंट के थ्रू वेटिंग करना इंपॉर्टेंट है. तो हमारी पद्मिनी कश्यप गायनेकोलॉजी शी इज इन चार्ज ऑफ मैटरनल हेल्थ, उसको पकड़ के मैं उसको बोलेगा ये फाइनल हमको एक मीटिंग मांगता है. 3 दिन के लिए हम दिल्ली में मीटिंग करेंगे और फाइनलाइज कर देंगे डॉक्यूमेंट और वीडियो कंसेंटिंग को, और बाद में दे करेंगे. तो हमको एलिगेशन नहीं होगा कि हम झूठे हैं, हम गलत कुछ कर रहे हैं, हम ऐसे करें वैसे करें. तो ये इम्पोर्टेंट है हमारे लिए. ओके. So thank you
Yes.
very much. Bye bye. I'm going to
Yes,
Lucknow for the UP Government Cancer Service launch is there tomorrow. All the ministry is there. So I'm going to Lucknow. I didn't want to go, but I said, नहीं जाएगा तो बोले कि FOGSI नहीं आया था तो
Best of luck,
जाएंगे.
sir. Best of luck. Yeah.
तो मैं आपका
Yes, sir.
सबका अलविदा चाहता हूँ अभी. Bye bye.
नहीं, अलविदा विदा कर दी.
Thank you
Alvida,
so
not
much,
Alvida.
Rishikesh,
Thank you,
for
doctor.
gracing this Chai Pe Charcha.
Okay. Bye bye.
Thank
Bye.
Bye, sir.
Bye.
Bye.
Thank you. Thank you, Bharti.
Bye,
Now
sir.
tell me how much time do we have for the panel, realistically speaking?
सर मेडिको लीगल आप पूछ रहे थे.
जितना पढ़ाना है पढ़ाओ, कोई
हाँ.
प्रॉब्लम नहीं.
Okay, medical legal में I think Dr.
सर
Shobha wanted to comment.
हाँ, उस पे फॉर्सेप्स से जो नर्व दबता है तो फेशियल पैल्सी हो सकता है, एस्फिक्सिया हो सकता है, इंट्राक्रेनियल हेमरेज हो सकता है, जिसके चलते रेजिडुअल इफेक्ट्स हो सकता है बच्चे में. एंड you said ki how it will happen. No, sir, I have there was one professor in our medical college, Dr. Sarojani, and forceps delivery was done for her grandchild, and he was deaf. So
Okay.
things do occur. और उस समय medico legal बहुत नहीं होता था, but now we have to be very careful.
We have to be
We
very
don't have
careful.
to apply much force, and we have to do it properly.
Also, can I add, Dr.?
Yes, Dr. Shobha.
Yeah. I just wanted to say that when the indication is fetal distress, then we find some compromise in the baby. Sometimes it is in the form of HIE. Sometimes it is intracranial hemorrhage secondary to prematurity or any other insult, but it gets attributed to forceps. It gets attributed to forceps. So it's important for us when we are applying in the procedure notes to apply how was the application, whether it was easy or difficult, whether all the steps were followed, whether the locking was easy or difficult, and then how many tractions were applied to deliver. I mean, one has to keep within the limits of safety and describe everything end to end in order to have a medical legal safe labor notes. Yes.
And Dr. Ranjana Khanna has raised her right hand, I believe.
So,
is it right hand? Yes. Yes, madam. Unmute yourself first. Okay. She can't unmute herself.
Sir, I can say it. Sir, can I say one thing, but when Dr. Anjana is coming? The basic thing is for that, I think what you said is the training part is very important, because right handling, exact, how much the blade is, when to apply, the rotation is complete, the longitudinal, the midline axis of the posterior axis of the is in the midline. That part is very okay. The suture, the blade should not be locked with difficulty, like I mean force se laga ke nahi kar rahe hain. There should not be this ki ek baar once we have taken a decision of forceps to forceps hi karni hai. If it is not going, one has to be ready कि हम shift कर लेंगे कभी भी. So that technique का those small points are very important. They should be taken care. Chances of complication reduce हो जाते हैं. There can always be something, but they are definitely decreased if your right technique is being applied. So that is important in training and skill labs.
Yeah, Dr. Khanna is
actually, I wanted to say that proper rotation should be there. We have to be very clear, and we have to teach our juniors exactly which is the anterior fontanel, how do we diagnose the posterior fontanel, because sometimes it so happens by the time the fetal head reaches the perineum, there is edema also on the scalp. So sometimes it becomes a bit difficult to diagnose. So we have to be very sure of the rotation, because I remember when I was doing my PG, there was a junior who applied forceps like this, anterior posterior. So what happened? And obviously it was a precious baby and the child died because of ICH. So what is very important is to diagnose the rotation of the head and to exclude CPD. Then and only then you should try. And the forceps blade, of course, as Kiran has said, they should lock easily, and then a steady force, not like this, you can't keep on giving intermittent pulls. You have to give one steady force and take out the baby. So these
Thank you,
things I
Dr.
think are very
Thank you,
important.
thank you, Dr.
Time
Khanna,
is
because
up,
of
sir.
time. Yes. And Dr. Alka Pandey, do you think that under the circumstances, a ventouse will be a better option? Would you apply ventouse here? And
Where?
which cups do you prefer? This situation that we are discussing now, the eclampsia case. And then how many pulls will you recommend? And
3
advantage?
pulls. 3 pulls, sir.
Okay, 3 pulls. And what are the, which cups do you prefer? Which cups do you prefer?
Silicone.
Silicone cups. Okay.
Dr.
Okay.
Ashish,
Yes, yes.
see, ventouse application in an eclamptic will cause little strain to the mother because she also has to push. She has to push with ventouse. So forceps is more ideal provided prerequisites are full, and especially the rotation.
Rotation.
If she is short of rotation, then probably ventouse is better.
Ventouse will be a bit difficult in the case of eclampsia 3 weeks over. But then the point is here, it is better to apply ventouse than apply a forceps where the sutures are not being taken care of. That's what I meant to say.
Yes, that's
sir.
when rotation is not
agree.
The rotation should be complete and release outlet forceps only to be
I mean,
applied.
that is more dangerous than a ventouse, perhaps.
So
now we come to the indication.
Add one alert. Just give me only 10 seconds.
Okay.
I wanted to add one alert that when it is a low forceps application of a good sized baby, if it is around 3.5 plus or even a 3 kg plus baby, the obstetrician and the team should be ready to manage shoulder dystocia. Because with the difficult forceps application, sometimes we see shoulder dystocia. So always difficult forceps we have to or even vacuum, we have to anticipate shoulder dystocia.
So now I will name some indications and some conditions where I just want to know whether all panelists agree to this or not. Fetal indications of ventouse in vacuum extractor. Fetal distress in the second stage, do you all agree?
Yeah. No. Ventouse, no.
No, I would agree.
Fetal compromise, we should not apply ventouse, but
we agree.
Ventouse should not be applied into fetal distress if there is
release outlet forceps.
No.
Okay.
Yeah.
So that's what Rishikesh wants to discuss in Goa. There is so much of differences in opinion. That's why he suggested the Goa as an excellent venue for all this discussion. So we will take one ventouse and one forceps in each of the in Goa and then maternal indications. Maternal
if forceps cannot be applied safely, then ventouse can be applied. There is no contraindication.
Okay, that's a conditional reply. You'll get a conditional drink on that. Hypertension, cardiac disease, and respiratory disease, etc. You have already mentioned about the maternal indications. Then come to the obstetric indications like borderline cephalopelvic disproportion, trial of ventouse. Agreed?
No.
Delay in the second stage of prolonged labor, do you agree?
Yeah, we can't.
Malrotation or attitude of deflection?
Yes.
Most of the things.
Depends on what, how much.
No, malrotation, why?
Not, it cannot.
Ventouse also helps in rotation. If there is slight rotation,
but in the modern, the recent studies say the ventouse should not be applied for the purpose of rotation.
That's right. But if there is a slight malrotation, say 45 degrees.
Very slight. Malrotation is a different thing.
Malrotation is different.
I
agree.
Malrotation, it should not be applied.
So these are the prerequisites for vacuum extraction. I think all of us will agree on this. So I'm skipping this slide. Next slide is the safety guidelines for the use of vacuum. Okay. Traction is applied only when the patient is actively pushing. If you disagree, please raise your right hand. Traction is applied only when the patient is actively pushing. Okay. Second point. Procedure should be, time from the first application of the cup of the delivery of the infant should be, should not exceed 20 minutes. Do you agree?
30 minutes.
20 minutes. Okay, 30 minutes. 10 minutes allowed. Procedure should be abandoned after the cup has dislodged from the fetal head 3 times. I think we'll all agree on this.
Yes.
Okay.
Yes.
Fine. Most of us will agree on these points. Thank you very much for your agreement. Now we come to the next point. Now, several randomized trials have compared vacuum extraction with forceps, and you're all aware of that. There is no scope of detailed discussion on the studies that have been conducted. But in a nutshell, if someone asks me to tell about forceps versus ventouse, I'll say less maternal trauma, less need for anesthesia, but more scalp injuries, cephal hematoma, retinal hemorrhages, and increased failure rate in case of ventouse. You all agree with this?
Agree.
Sir,
These are the pictures.
Sir, can I say in one word?
Yes, yes.
Sir, in one word, ventouse is better for mother, forceps is better for fetus.
Okay. Okay.
Forceps is more
Do
protective
you
for
agree
the
with that,
fetus.
Dr.
No, no.
And
I would like to tell it in the other way.
mostly in major things. If you
In
see
majority
the
of the cases,
differences,
it's a general statement. It's a general statement. It's not always true.
it's a
The
general
other way
statement.
around is forceps causes more maternal injury and vacuum can
Yeah.
cause more fetal injury. That is the better way to take it. Yeah.
So the advantages
Yeah,
of
that is what I'm saying in other
ventouse,
words. That's what I'm saying in other words.
the traction force of ventouse is less than the forceps, which is 10 kg in case of ventouse, whereas in case of forceps, it is 18 and 13 respectively for primigravida and a multipara. So therefore, I think it reduces less traction force. That's one advantage. Lower rates of maternal trauma and genital tract lacerations that we have all agreed. Anesthesia need is less. Anesthesia need is also less. Mother feels good. To me, it's a very important fact is that the mother feels that she has delivered the baby herself because the ventouse cup has to be brought down with the maternal pushing effort. Postpartum maternal discomfort or pain is less compared to forceps and shorter learning curve compared to the forceps, good for the trained midwives. The last part, I don't know how much of you agree. Many of you agree that trained, it's for midwives, it's a better instrument than forceps.
Yeah, learning curve is shorter. Yeah.
Yeah. Now, what are the advantages of forceps over ventouse? Let us see. Forceps operation can quickly expedite the delivery. You all agree? It's safer at any gestational age, even less than 36 weeks. It can be employed in the anterior phase or in aftercoming head of breech where we cannot put ventouse. Agree? Lesser neonatal health, scalp trauma, retinal hemorrhage, jaundice, cephal hematoma, higher rate of successful vaginal delivery. Different types of forceps are available for outlet, mid-cavity, or rotational delivery. Traction forces is more about, as I already mentioned, 18 kg and 13 kg respectively. So what are the contraindications of ventouse? I think Dr. Alka Pandey, and you can elaborate on that.
Yes, sir. In cases of preterm baby, and even when the baby weight is more than 4 kgs, then if the baby has
presentation,
anything except vertex, it should not be applied.
Yes.
And bleeding problems if they have
The vertex is a presenting part. Vertex has to be the presenting part. Cephalic presentation, but in cephalic presentation, other presenting part are not allowed, like face, brow, and breech, of course, not allowed. So there is one question for Dr. Pandey, Dr. Kiran Pandey. Do you routinely use forceps or vectis in C-section for the delivery of the baby?
No.
No. Sir, when we were resident, my teacher used to use vectis a lot, but we have not been using it honestly, except the high floating head. Sometimes it helps into it. Although now the technical aspect of high floating head delivery is also different. I mean, we are not going into that, how to stabilize and to fix it and then take help. But
So
their vectis does help.
Yes. And do you routinely use forceps in assisted breech delivery after coming out of the breech?
No, sir, because long forceps are not available now in the medical colleges also. For that, you need, Piper is not available, long forceps are also not.
Piper you can easily get, madam. You order Piper and Piper will be there for you.
Yes, we can get, but nobody has used it. So now it is totally gone out of.
But I believe that the Das's forceps is a good substitute for Pipers. At least wherever I have needed.
I say personally.
Okay.
That's what I was saying. Personally, because I was trained in KGMC, Lucknow Medical College. So I have done all these procedures personally speaking.
Okay.
But in medical college, routinely people are not doing this.
So this is the famous rule of 3 of vacuum failure. One is 3 pulls over 3 contractions, no progress. 3 pop-ups, after 1 pop-up, reassess carefully before applying, abandon after 3. And after 30 minutes of application with no progress, reassess once again. I think we have come to the end of our panel discussion because the time is very, very limited. And I have put up some points which are takeaway messages for the delegates and all of us. the number one point is instrumental delivery has never been without critics from the point of its inception up to now, and is not without risk also, but it remains an important armamentarium of the modern obstetric practice. Do you all agree with this? That means it's a necessary evil.
Yes.
It's a very important part of the discussion, but actually it has never been without critics. Second point.
Ashish, just
Yes.
one concern
But
here
it
is
saves
we did not discuss the consent aspect, and we need to standardize, say that
Yes.
it is a verbal consent which we take so far.
Yeah, no. The concept is of course there, but we have discussed everything because of the lack of time. Okay. Concerns are intrapartum asphyxia and to a much lesser degree interpartum trauma to the mother. Okay, these are two concerns. In modern obstetric practice, even a high rate of C-section has not been able to eradicate maternal and, more importantly, fetal morbidities. The pros of a successful IVD must be weighed against the cons before calling it obsolete. So there are some people of us who are a bit hasty, who call it an obsolete art, the instrumental vaginal delivery. I strongly refute this agreement, this argument, and I believe my panelists also agree with me.
Shall I say something, Dr. Ashish?
Yes,
Hello.
Dr. Parul Kurtawala, it's a pleasure hearing you.
So I object to your description of necessary evil. I would
Okay.
say it is a boon, provided you use it judiciously.
Yeah.
Right.
Okay. That is
Sorry
the
for this.
That
But
is the
I
definition.
am very
And that is the
strong
definition of
proponent.
necessary evil, sir. What you just said is the definition of necessary evil.
No.
Okay. At least some reduction in the escalating rate of C-section is expected. I have been very modest. I have said some reduction because I don't believe that forceps and ventus will be able to drastically reduce the rates of cesarean section. I don't contribute to that belief. Next point. When spontaneous vaginal delivery does not occur within a reasonable time, a successful operative vaginal delivery trial avoids C-section with its antecedent uterine scar, implications of future pregnancy, and most importantly, the placenta accreta spectrum. I think that today's students, today's juniors, they forget that this kind of an existence is there. Placenta accreta syndrome, particularly today's obstetrics, is very different because we're having a lot of IVF babies and a lot of placement inside the uterus. So I think that the time has come that we should teach them in the line of these complications, lethal complications. Till they face these problems, they won't understand this. Assisted vaginal delivery offers the option of an operative procedure to safely and quickly remove the fetus, mother and obstetrician, from a difficult or even hazardous situation. It definitely remains a ray of hope when minor disproportion, prolonged second stage of labor, fatigued mother, and distressed unborn and concerned physician are all concerned. Let us all use vacuum extractor or obstetric forceps judiciously and augment the forces along the pelvic curve. So that's the bottom line, that if we, so long as we apply the forces along the pelvic curve, be it a forceps, be it a ventus, I think we'll do a lot of benefits to the mother, and we'll try to reduce some of the cesarean section rates. I have had a calculation of this amount of cesarean section rate reduction. I'm not mentioning that because of I want to avoid controversy. It's already almost 6 o'clock. So I would like to thank you all my panelists and thank Bharti Maheshwari, our president, Dr. Rishikesh Pai, our Secretary General, and all other dignitaries tremendously for giving us this opportunity. Thank you very much.
Thank you, Ashish sir, and thank you
very much, sir. So you made the panel very interesting. Besides the technical, you made it very interesting.
You have covered lots of things. So now please stop sharing.
Thank you, Dr.
Thank you all panelists, and very good discussion. And without doing any delay, we come to the next topic, and that is difficult labor. And we have with us panelists. They are very they are very academic and active FOGSians. Then our panelist is Dr. Sheila Mane Madam. We all know about her. She is the ICOG Vice Chairperson elect 2022-23. Welcome, Madam. Then we have Dr. Shamila Ayabu. We all know that she is the Vice President elect FOGSI 2024. Welcome, Madam. Dr. Reena Vani. We all know that she's a professor and head of Gynae HPT Medical College and Dr. RN Hospital, Mumbai. And then we have with us Dr. Vidya Topi Madam. She's a professor and head of Gynae Alamin Medical College, Jaipur, and the FOGSI committee chairperson. So with this, we come to our panel, and that is on the difficult labor. We all have that we have less time, but we will try to finish in as much as possible in less time. So I have introduced my panelists. So first things what comes to us in mind, what is the difficult labor or what is abnormal labor. So define abnormal labor, first we must know what is actual normal labor, and that must be understood and accepted. So all of us, we should learn it thoroughly, and by following thousands of labor resulting in uncomplicated vaginal delivery, time limits and progress milestones have been identified that define normal labor. So failure to meet these milestones define abnormal labor, which suggests an increased risk of an unfavorable outcome. And abnormal labor alerts the obstetrician to consider alternative method for a successful delivery that minimize risk to both the mother and the infant. So dystocia of labor, it is defined as difficult labor or abnormally slow progressive labor. Other terms that are often used interchangeably with dystocia are dysfunctional labor, failure to progress, lack of progressive cervical dilatation or lack of descent, and cephalopelvic disproportion. So now comes to each panelist one by one. What is in their life difficult labor in your experience, or what comes in your mind when you thought about the difficult labor? Dr. Sheila Mane, madam.
Bharati, can you make it into a slideshow?
Pardon?
Can you make it into a slideshow, because it's partially seen.
Slideshow.
Yeah, thank you, Bharati. When you said that difficult labor, okay. So now when we talk about labor, we have different stages, that is first stage as well as the second stage of labor. So we have to start assessing from first stage as well. Now, all of us, we know that the latent phase, which can be prolonged, because the time differs in a primary and in a multi, which all of us we know, but sometimes it is unnecessarily prolonged. And we also get worried. I mean, we think whether we are trying to intervene early, unnecessary examinations or something, but we do find that these patients, they do not progress well. And later on, when we try to do the NST, we find that there are variations because she was for a long time. So it could be a dysfunctional labor. Then coming to dystocia, as you told, sometimes we have seen that the cervix fails to dilate. We feel that the head is coming down, it is 4 to 5 centimeters dilated, we give augmentation also, but still it does not progress and it becomes a difficult labor. And sometimes, the second stage really gives us problem. And it becomes very difficult because, again, doing a cesarean at second stage, a very late second stage also becomes difficult because it increases the morbidity for the mother as well as for the baby. So these are the difficulties usually we find in labor, and non-progressive labor, which we call it as sometimes when they don't progress early, and even in late first stage or second stage, we find that it has become the protracted labor. The patient, there is no descent. So like that, I would like to say that in my personal experience, I have faced this situation.
Anyone other want to add something other? Yeah, Dr. Chamila?
See, difficult labor is usually a retrospective diagnosis. You assume that you're going to go for an easy delivery. And when it happens and you actually put all your partograms and everything, you'll be going ahead with one intervention of the other. And then when you land up with a problem later on, then you have a diagnosis of difficult labor, because you should not have a difficult labor if you have assessed the patient properly. So the difficulty will happen with the attenders, the patient. It can be anywhere the difficulty can happen. Nowadays, it's not difficult labor. We can manage it quite well if you put up a proper protocol for your center. But the difficulty happens with the attenders and the patient also. So keep all that in mind when you're going for a normal vaginal delivery for any patient.
Dr. Reena Vani, you want to add something for difficult labor?
Dr. Bharti, Dr. Reena Vani here. What I would like to add is that dystocic labor is hard work. That's why we call it labor. What is important is that, and as beautifully put up by Dr. Lakshmi Srikhande in her Robson's classification discussion in the starting of this program, that a lot of sections which we can prevent when we have loosely labeled this as dystocic labor. The primary cesarean can be prevented by that. And hence, what people are not following, even in medical colleges, we have to insist that the WHO partogram or any basic partographic management of labor should be emphasized, because it's a very simple tool which does not require too much effort. Dr. Haresh Doshi also talked about the fact that intermittent auscultation done properly and professionally without having continuous CTG can also improve the outcome. And why has the WHO in its bundle of interventions talked about in labor management involving midwives and nurses? Is because we are talking about simple interventions. So I feel we as obstetricians, and perhaps following what our president, Dr. Rishikesh Pai, just said, is that let's have some kind of standard protocol across the country, which will tell us that, okay, at this point, we should label the labor as dystocic. And let us, a simple way is to use simple tools which are available to us across the country and not talk about things which are very hi-fi. That's what I wanted to add. Thank you.
Do you want to say in your life some experience about the difficult labor? Dr. Vidya?
Yes, Dr. Bharti, this is very interesting panel, and I must say that we do come across difficult labor, and as Charmila told, it is always a retrospective diagnosis. And always, if you follow the protocols, definitely we call of 3 Ps, that is the power, passenger, and passage. So unless we assess all the 3 properly, so labor will be very smooth, but it doesn't happen because the assessment and assessors, everything goes wrong at some times or some ways. So we have to assess properly, we have to follow protocol, and then this difficult labor does not happen. But we all know that we, as a tertiary care or as a referral center, though 80% of the labor take place in the institution, we do get this difficult labor because of not proper assessment. Yeah.
So Dr. Sheila ma'am, can we anticipate earlier abnormal labor, that this patient can have abnormal labor? What are the important factors? Yeah, madam.
Yeah, I think antenatally, when the patient is coming for a regular antenatal checkups, the definition now, you know, that the head should get engaged in a primary is not seen anymore, but that does not mean. But the main thing is that is near term, we will have to rule out cephalopelvic disproportion, which is very important. Another is obesity, maternal age, which is on the rise if the patient has polyhydramnias, okay. Pelvic contraction per se, we don't find, but height of the patient is again a very important thing. Now, antenatally, if we have to assess, then polyhydramnias, and if we find that it is a deflexed head, when the patient has come in, just she is she's nearing the day, she's 40 weeks, we find that it is a deflexed head. Yes, these are the things which will tell us now. Now, during labor, the factors are different, okay? Because during labor, you will find so many others. You asked me about antenatally, so I'm trying to tell this. These are the factors which could be assessed antenatally to know. Even oligoamnios, because, you know, there is no force of that amniotic fluid during labor, the formation of sausages of that like thing of the membrane, which won't be there with oligoamnios. All those things. And regarding the, fetal side also we have to take into consideration, because if we are not with the fetus, happy with the fetus, and sometimes if the patient has associated comorbidities, we will also have to take that into consideration. Like diabetes, we will have to assess the weight of the baby and decide whether we can allow her for vaginal delivery or we have to take her for a cesarean. All those things will come antenatal.
At the antenatal time, we can detect, we can anticipate for the problems in the passage or passenger. And during the abnormal labors, you can maternal risk of abnormal labors. If like that woman can have abnormal labor, what could be the risk to that woman and fetus?
If it is an abnormal labor, see, the maternal exhaustion will be there. Okay, everybody, all of us, we know that we maintain the partograph. We have now the WHO care guideline where we have included even the second stage now.
Yes.
Okay, so in that second stage also need monitoring. That means because we had only alert and action line. So the maternal risk is always there: prolonged labor, infection, chorioamnionitis, postpartum hemorrhage, exhaustion of the mother, late decision for cesarean, infection. For the fetus, all of us, we know it could end up in instrumental delivery. We had such a beautiful discussion, the fetal risk, hypoxia, and then, you know, we are seeing so many HIEs happening later on. Chorioamnionitis can lead to pneumonia in the fetus. The first and second day baby is fine, third day baby goes to NICU, meconium aspiration. So these are all the problems of abnormal labor.
Very true.
So
Not
yes,
only,
we have to assess.
yeah, very true. Not only increase incidence of cesarean, but there are lots of problems. So at any point, we have to identify and anticipate the abnormal labor, and we should manage it earliest. So Dr. Shamila, there is a one situation, one primary 39 weeks pregnancy report to you labor room at 6 a.m. She is having 1 to 2 contractions in 10 minutes. And when you do the parvaginal examination, you see that she is 3 centimeter dilated. History of pain she is having since last 6 hours. And after 4 hours, 5 hours, she says that you again did a PV, and even after next 10 hours, the findings are same. So what is this condition? What is ideal duration? Is it latent phase or not? What is ideal duration? When intervention has to be required? What are monitoring tools, Dr. Shamila?
It is actually latent phase because she is perceiving uterine contractions, but there's no cervical dilatation. She's stuck at 3 centimeters for almost like 4 to 6 hours. So in the latent phase, it's better that you don't do any intervention. The thing is, you have to offer her pain relief because she's suffering from that pain, and that may cause problems later on in the active phase, and give her good companionship. So you call the attenders, counsel them, and tell them this is just latent phase and she's not going to deliver soon. So it's better that they are reassured, because they are the ones who will cause the problems later on, saying my wife has got admitted for such a long time, nothing is being done, and they want a normal delivery even at the latent phase. So the counseling has to be done to the attenders, and a prolonged latent phase is one. According to the RCOG, it's like 8 to 18 hours can be in the primary gravida. So it can vary from 8 to 18 hours. So, but how the patient and attenders bear that will give us the results also. So if it crosses 8 hours, I think we have to be a little more careful, do an assessment again to see why she is in such a long latent phase. Wait, if they are agreeable, wait till at least 16 to 18 hours to see what's happening, but provide a pain relief. When you give pain relief in the form of whatever is your protocol, and the patient settles down, and then she will go into active labor by herself. But do not give oxytocin, which will not help in the latent phase. Do not go for ARM, which will also not help in the latent phase when the contractions are not good enough. She's just having 1 to 2 contractions, and if you think you can increase it with your oxytocin drip, it's doomed to be a failure. So keep it in mind and provide pain relief, reassurance. And sometimes I think giving an enema helps also, even though the Western guidelines do not agree. Giving an enema for a person in latent phase helps usually to settle down her so that she's got time to go into active phase.
So very true, you have covered all issues, Dr. Shamila. So basically, latent phase we must observe closely, and we should not do over treatment. We should try to find out if it is prolonged, then there could be some further abnormality in the liver can come. So we must remain for the close monitoring and of course counseling of the patient. Then Dr. Reena Mani, madam, that then the patient comes to you at 4 centimeter dilatation, and when you do monitoring and do the internal examination after 4 hours, then it is 6 centimeter. And then after 4 hours again it is 6 to 7. It is not progressing, and you see the head is still at -2 station. Then how we should approach or we should proceed for the management. Role of partogram, of course, in the first stage of labor. There are lots of type of partograms, lots of things. So what is it exists, and what types of monitoring in first stage are recommended in India? Dr. Reena Madam.
So, Dr. Bharti, what you have actually classically described is a secondary arrest of dilatation, in which we have to look at whether it is a uterine factor or whether we have missed something in the fetopelvic disproportion. And Philpott and Castle had talked about the alert line and the action line, which I think a lot of people are not following to this date. But that, if we would plot the partogram in this case, you would find that the labor progress is crossing that and towards the danger zone, which means that we need to intervene. So this actually, the whole concept of the partogram was more for where it is midwifery based care, where you need to call in the consultant. But when we are working in teams and you have somebody who's managing in private practice, you are the whole and soul. So I'm sure a lot of practitioners are also following it. But even there, for your own medico-legal protection and other things, when we have talked about when to intervene, this is a classical indication where we will see what is the station, look at the station, rule out cephalopelvic disproportion. If there is hypotonic uterine action, we will augment it. And obviously, if there is any other high risk factor or other things, this is a woman where despite your WHO rate of 10 to 15%, if she is not progressing, this is a woman who is asking for a cesarean section. And in that case, you might have to intervene because this is truly dystocic or abnormal labor if after correction of these correctable factors, she has not progressed.
So very true, Reena ji, because we do paper with under examination only after 4 hours, so we can anticipate or we can identify earlier that labor is not progressing, and we can find out the cause. And this is very simple partogram graphs. By only visualizing the graph, you can see that this is the, you can see that it is so long. The line, this is line, so this is the arrest latent, prolonged latent phase. You can say that this is the prolonged active phase, and यहाँ पे static है पूरा, तो खाली visualizing the line you can see that this is a
one more important point which I forgot to mention: the anterior shoulder is, you know, even if you're not doing a pervaginal examination, when there is descent and movement, in fact, a very famous obstetrician from Mumbai, Masani, Dr. Masani, had described Masani's rule that as the labor progresses, even if you do not do a pervaginal examination, the movement of the anterior shoulder downwards and towards the midline will just by per abdominal examination tell you that labor is progressing. And another thing which we describe is the palpation of our head by fifths, that even if on PV we are not able to see, because the descent is again a subjective thing and sometimes the caput may fool you. So Crichton's method of palpation by the head by fifths, that if you feel that the head is also descending down, all your interventions are working, then even if, you know, these are all other ways that we as clinicians can support that the labor is progressing. And if it is not happening, then of course we go in for a active intervention.
And beside conventional partogram, what we have all, nowadays we have seen that everyone is, they have increased the practice of using it. At every hospital I have seen the papers of partogram. It is in every file, so definitely the papers become more alert and they are using it. And nowadays we have electronic partograms also, that it is in the, there is a simple sensors kept on the predominant point of the motor pelvic bone and monitor fetus position in relation to pelvic bone movement. जो fetus का होता है, they can monitor in the electronically. Of course, it is not common in our country, but definitely the one way will date, then one can monitor at any point, like from the phone and from the your place, you monitor the fetus progress. And beside that, the WHO labor care guide. This is very much nowadays in the discussion what the person has to follow, whether the conventional partogram or WHO labor guide. So there are some small differences. First thing, that as the modified WHO partograms, already we have started the cervical dilatation or latent phase after 4 centimeter. In this WHO labor care guide, it is done from the 5 centimeter, and beside that second stage is added in this. So this is not very different. Those who are using the partograms, it is the same. In anyhow, you can just see the progress of labor, and computerized labor monitoring, they are also in the available in the world, where the simple by computerized labor management system, fetal condition as well as maternal condition, one can see on their devices. So this was about
Bharti, I just wanted to say that all of us are talking, even the timings for the second stage is also more in the WHO care guideline. Like if everything is normal, they say 5 centimeter dilatation, you can still wait for 7 hours. There is no rule of that 1 hour, you know, like that. 7 centimeter dilatation, you can still wait for 4 hours if everything is okay. And second stage of labor, you know, like if there is no epidural anesthesia given, you can wait for 2 hours in a primary, and with epidural 3 hours. So all those things are there, but that requires monitoring and patience, which is very important. You know, you have to maintain the hydration of the patient, the continuous monitoring of the FHR, because, you know, after the full dilatation, what happens is everybody starts getting worried that the patient has to push. So, and the position during labor plays a very important role here. We don't have to put her in dorsal or lithotomy position and ask her. We can just ask her to take her own position, and after full dilatation also, she can just be in any position, can go on pushing. So the position of labor will, in labor, will play a very big role if we want to really achieve a vaginal delivery.
And monitoring, we can watch for the prolonged labor, and definitely CTG correct interpretation, that is also very important. So that is the thing. So clinical, next we comes to the Dr. Vidya Thobi madam. That is a very important part. Already Dr. Sheila madam and all has told that clinical detection of passage means pelvis assessment and CPD. From very beginning it is very important. So madam, how we should approach, and just to revise.
I just wanted to comment here that whenever we talk of contracted pelvis is anatomical definition. Of course, when we talk of when we teach our postgraduates, a pelvis where one or more its diameter it is 1 centimeter or less, we talk of it is a contracted pelvis. But when we talk of obstetrics, so pelvis in which the diameter is reduced, that is, it interferes with the normal mechanism of labor. That's what we talk of. And inlet contraction, you can just put, you can measure the diagonal conjugate and the obstetric conjugate clinically. And that too, they say that this diameter should be used, means measured at 37 weeks. Of course, labor care guides, they have excluded the pelvimetry as such, but we always talk of various methods how we can detect the CPD, that is a cephalopelvic disproportion. Just as Bharti is showing the picture, we can measure just reaching the sacral promontory, or just pushing the head inside the abdomen, putting your 2 fingers over the pubic symphysis can sometimes detect, but many times the patients are obese. There are other things which interfere for the assessment of CPD. So the pelvimetry, clinical pelvimetry is the best what we always teach, but there are other methods like CT, MRI that can also be provide accurate diagnosis, but they are very costly. So one has to means if the patient walks in, if you see that her height is less, if she is using simple is 4 number ka shoe, then definitely her pelvis is contracted. That's what is what our teachers used to teach us. So there are other methods. We know iron donal method is there, Pinard's manure is there. Apart from our standard CPD assessments, we can put your fingers at the ischial spines, push the head from above with the left hand finger, means hand, and just see that the head descends. But I don't think that present era of diabetes, macrosomic babies, many of our cesareans go towards CPD and fetal distress. So CPD is a common diagnosis what we made in the present era. So diagnosis of CPD should be done at term, and when the patient goes in active labor in some time, means in some of the patients. So
what are the absolute indication when you do the cesarean section for contracted pelvis?
So in moderate disproportion, definitely we can go for trial, but then we have to take proper consent and we have to monitor these labor very carefully. We have to put them into monitor, and we have to put the proper partogram, see for the descent, dilatation, and whenever necessary, we have to augment also with the oxytocin when the powers fail. So these things definitely one should follow.
So very true that the assessment of the passage is very important, and it is at the 37 weeks, and at that terms you have to see, and even once at the very first antenatal visits, one do the PV, then they have idea if there is a very gross abnormalities, one can find out in the close monitoring.
One more thing, Bharti, though earlier we used to say that the flat pelvis is the best pelvis for trial of labor. You know, because the anteroposterior diameter is short in a flat pelvis. Once it negotiates the brim, you know, it can easily come down. So there are different types of pelvis which we talk about. We may not find that much now. We find mainly the gynecoid, anthropoid, and android. But flat
always mixed variety.
Mixed variety also. Yeah. But flat pelvis, you know, where the AP is short.
Okay. So now we come to this is the passage. Now to come to the passenger. Dr. Charmila, there is what are the different type of malrotations, clinical detections we can do clinically, and then how we have to confirm it.
Yeah. Before I go into that, I'll just say like it's very difficult to do a pelvimetry before she goes into labor because they don't even allow pervaginal examinations nowadays. So it's so difficult. So once in labor, the problem is much higher. And what Sheila madam said that regarding second stage, it's actually, according to the American College, you can wait for 3 hours without an epidural and 4 hours with an epidural for a primary gravida. And Royal College is very clear. 0.5 centimeters per hour is the expected rate of dilatation. That American College of waiting for 4 to 6 hours is not acceptable according to the Royal College. So when you come to occipital mal rotations, in Tamil we have, in Trichy we have got a temple called as a Rockford temple. So when you have an occipital posterior position, when you do a per-abdominal examination, you can see something like a temple sitting on top and it will be totally flat below. Below the umbilicus, you find flattening. That is an indication that there may be an occipital posterior. You will find very easy to find the limbs, but the back is so difficult to find out. So that is one indication that there's an occipital posterior position. And when you do a pervaginal examination, the head will not get engaged so quickly in an occipital posterior. It takes time. And when you do a pervaginal examination, you will see that usually it's a high head. It won't descend. That engagement does not happen quickly in an occipital posterior. And the membranes will be feeling a little different. They won't be applied to the fetal head. It will be like a sausage shape. It's so the membranes will be classical for that. And there's a tendency to have an earlier rupture of the membranes. It will not happen with full dilatation. Even at 3 to 4 centimeters, the membranes can rupture off. And you can easily feel the anterior fontanelle, which is not so easily done with the occipito anterior. So when you see this type of per-abdominal and per-vaginal examination, be ready for a prolonged labor, do counseling of the patient. We have had phase 2 pubis delivery, and that happens quite often, but sometimes it may just go for an arrest of labor. I may need to go for a cesarean section, even in an occipito posterior position. If it does not rotate correctly, it doesn't happen in every labor. You have to be very vigilant. And regarding the other malrotation, that is the face presentation. You will feel the chin when you're doing a pervaginal examination, and that's I'm telling you, like, it's so it gives you a nightmare. You will not know whether this baby is going to come down and all that. So I delivered one mento anterior, but usually we go for a cesarean section when you see a malrotated baby, because it is so difficult to rotate them into the proper position. And the other one of brow presentation, when you feel the orbital ridge as well as the nose, then that is one of the most difficult things. And she comes in already in prolonged labor, and there's already a dystocia happening there. It's safer to go for a cesarean section when you see any of these malrotations, except probably in occipito posterior, when it's a favorable pelvis, a multigravida, she can deliver vaginally. But I've delivered even in preemies phase 2 pubis. It happens in a group of patients, but always be ready for prolonged labor. And for mento posterior, there's no indication for vaginal delivery. You'll have to go for a cesarean section.
So basically, Dr. Shamila, when everyone should know, even the staff and nurse and all subordinates, and when they are doing the pervaginal examination, if they are feeling the root of nose or orbital ridge, then definitely it cannot be delivered. So continuously doing the trial of labor and obstructed labor, that should not be done. And beside that, if one is feeling the chin, mouth, jaws, nose, orbital ridge, then definitely mento face presentation could be there. But if there is a root of nose, then definitely not. And then Dr. Reena madam, there is a 32-year-old woman that she is gravida 4 para 3 live 2 with 36 weeks of pregnancy, presented in casualty with labor pains this morning, no history of leaking, and she's having this finding that she's having a good uterine contraction, thumb size uterus, hard globular structure in fundal grape, soft broad structure in pelvic, 144 fetal heart sound, and PV may fully dilated os, membrane absent, finger is passing into anal opening of fetus, and buttocks are filled. So what things come in your mind and how you will proceed for the management?
Dr. Bharti, you've put up a very beautiful picture of a multigravid patient with breech fully dilated. And in fact, Dr. Shirish Sheth, our past president of FIGO, had said the true test of an obstetrician's skill is to observe how they can deliver a breech. And please remember, the maneuvers to deliver a breech vaginally and at cesarean section are almost the same. So it is actually, the first thing is that be patient. Allow the breech to descend, rule out any factor. Now, the fact that the patient is already fully dilated is a very good factor, but resist making her bear down until the breech is crowning. Assess she's a gravida 3 para 2, look for episiotomy indication, although the perineum may be stretchable. This is an indication where an episiotomy may be helpful. Keep an assistant at hand. And it has been said that there are 2 or 3 guidelines. One thing is we have to ensure that, of course, we have ruled out any other factor, augment, have a IV line patent, have the oxytocin at hand because you may require a little bit of augmentation. Keep the back anterior. And in an assisted breech delivery, I will be very comfortable waiting, and we have to wait until the baby delivers spontaneously up to the umbilicus. So watchful expectancy, patient observation. Once the umbilicus is delivered, palpate the cord for contractions and for the heart rate. Again, be patient until it has been said the tip of the scapula is seen. That is when the shoulders have entered the pelvis and are undergoing internal rotation. That is when we go into action and start hooking out the anterior and the posterior shoulder, gently shifting the baby using a towel to wrap the abdomen, avoiding undue pressure on the abdomen. Another wonderful guideline is wait till the hairline or the nape of the neck is seen. That tells you that the biparietal diameter has got engaged and is now in the position to deliver. We have many maneuvers described to do the delivery of the head in breech. The simplest is, of course, suprapubic pressure, the Wiegand-Martin maneuver, the Morisot-Smelly wheat we've all used, but a very simple thing based on physics is the Burns-Marshall, which we have used in vaginal birth and breech. Allow the baby to hang by his own weight until and grasp the ankles, sweep up towards the abdomen in a long arc, and the head comes out in the short arc with the fulcrum being the pubic symphysis. Believe me, it is a wonderful feeling to have a successful vaginal breech delivery. But be prepared, supposing there is a crisis. You may have to give something like a uterine relaxant if the neck starts closing down after delivery. But believe me, in the picture you have described, 95% of the times things will go well and you will be able to successfully achieve a vaginal delivery of the breech. So I think this is an art which all of us have to learn, and even at the time of cesarean, these same tips have to be followed, except for the Burns-Marshall maneuver. All the maneuvers to deliver a breech at cesarean are the same as what we described for vaginal birth.
Karina, you very beautifully described, and definitely all will be motivated to do vaginal delivery in the breech, in the multi. And what are the absolute indication for cesarean in the breech?
So this is actually very clearly, of course, if it's a stargazing fetus with an extended neck. If there is fetal-pelvic disproportion, of course. If it is a preterm breech, where typically the narrow body comes out and the head, which is wider and conical, is likely to get stuck. And of course, very important is the consent of the patient. We have to, like, for example, VBAC, one of the first things you have to do is ask the patient, is she willing to take that 5% or 10% chance in the thing? And of course, we have the Zattuccini and Ross score, which can be used. But at that time, when the patient is in labor, these are a few tips which are important in your judgment of how to go about things. PROM and a prolonged leaking of membranes with a dry labor, again, is an indication for cesarean, because, and in fact, it has been said that if the membranes are intact in a breech delivery, even till full dilatation, it is more helpful not to rupture the membranes because they will act as a protection for the umbilical cord. It will help in effective dilatation of the cervix, and you can rupture the membranes when she's fully dilated. That is the right time. So these are a few clear-cut indications. And of course, if it's a previously scarred uterus and other factors which are there, placenta, low-lying, those are a done thing. But the specific features related to a breech are what I have described. And of course, if the baby is more than 3.5 kilos, again, that is also an indication of cesarean section.
Dr. Sheila Mane, madam, one thing I just wanted to ask you, because you are a very senior experienced obstetrician. Madam, you have done, I think, manual rotations in many cases of osteoposterior position. What is your experience, and nowadays what you recommend and what you want to give you message to young generation? Yeah. Sheila Mane, ma'am.
In those days, like we used to get mainly referred cases, where we used to apply low mid cavity forceps. Now it is not there. There is to be already a caput, okay, and deflexed head. We had to wait for some time, and sometimes even if the one pole was palpable on per abdominal examination, okay. Now, if it was a short, malrotation was there, yes, we had to go inside, feel for the pin of the ear, find out whether it is a right occipito-posterior or a left occipito-posterior, because that would decide how we are going to rotate the head. And depending on that, we had to rotate the head and then apply forceps and deliver. Now, I have not applied, to be very frank, the Keelan's forceps, even though it was there, but a few of my colleagues were there who used to apply the Keelan's forceps also, but only in 1 or 2 incidences I have seen that. So the vacuum usually by that time there is to be so much of caput that the vacuum was also not very useful. But now what we see, today's practice, when we see that there is a malrotation, most of the time it is in transverse. And if the head is descending, we are satisfied that there is no cephalopelvic disproportion. Sometimes we know that we can deliver this patient, we do use vacuum. At least that helps to bring down the head. And then later on, after the rotation, we apply forceps if we find that the vacuum is not fitting properly. And then we deliver even with combined efforts also, that is vacuum as well as forceps. So earlier days, we have tried that. And today also, sometimes, we find that we are able to rotate and then we apply forceps. We find that there is still, it is short of little rotation. What we do is we apply the forceps, we try to press the forceps blades against the porchet. That itself causes that lever mechanism, which helps the head to rotate. Okay. And then we lock the forceps and we deliver. Another thing is, if we find that there is a lot of overriding, that is molding is there, and particularly that asynclitism, we have to see whether it is anterior. But nowadays, what happens, most of the time the decisions are taken early. So if it is occipito-posterior and the weight of the baby, what we find nowadays is there is an increase in the average weight of the baby. When we were young, we used to deliver comparatively the smaller babies. Now here, once the baby has crossed 3 kgs, 3.2, all these things becomes really difficult. And if we find that it is a prolonged stage or a deep transverse arrest, the patient goes for cesarean section. Now, one most important thing I tell my postgraduate is try to learn to palpate the sagittal suture to diagnose whether it is occipito-anterior and posterior. If you feel anterior fontanelli on vaginal examination, it is either a deflexed head or it is a malposition or a malpresentation like bro. Be careful. So try to palpate that, not only dilatation and all that, and that will keep them aware that it is an occipito-posterior position and the patient needs more attention and we may have to augment the labor.
That is very true, madam. It's a very useful thing for those who are attending. So then we come to the Dr. Reena already told about the breach, but all breach is not necessary. Can
I just add one thing? Now, just recently in AICOG, we met the FIGO faculty from Germany. Sorry, I'm not able to recollect. He is doing the breach Frabat program. That is the delivery in upright position or knee chest position. And I was surprised to see that no manure, the way the patient progresses and the breach just drops down, no manure is done. But it is in the white people. I really have to, see that whether it can be applied in our country and our situation. Yes, all these factors, what you have told, absolute indications, we will have to take the patient's, the baby weight into consideration and all those things. So that is that Frabat program.
Yes. So now the last question, Dr. Vidya madam, this is also the doctors want to know that if the situation when a woman comes to you, gravida 2, para 1, live 1 with 39 weeks of pregnancy, presented with labor pain since 4 hours, and when her PV examination is done, then bag of membrane got ruptured and cord was filled. So what exactly you have to do? Yeah, madam.
Once the diagnosis of cord prolapse has been made in a viable pregnancy with the confirmation of live fetus, so what we have to do is it should be very urgent. It is an obstetric emergency. So you have to call for help and try to manually replace the umbilical cord into the uterus by anybody who is there available in the labor room, who should continue again, and they say about the knee chest position and all, but it is very difficult to give that knee chest position. What we do is we fill the bladder around, but recently we had a cord prolapse and we could save baby. The labor room and operation theater should be very near, and we have to call help, means we have to call all anesthetists, everyone, and that is urgent only. Give oxygenation by face mask, access of IV, transfer the patient immediately to the operating room. Now here you need not go to the ultrasound room and go on doing ultrasound for anything. So it is an emergency and you have to take the consent, which is very important, that you are saving the baby, and they will not see the cord pulsating cord or whatever prolapsed cord. They will not be able to see the relatives, but you have to counsel. One person should go for counseling again. Now, another thing I just want to highlight is prevention of iatrogenic cord prolapse. So whenever you are doing amniotomy or artificial rupture of membranes, only you have to do once the vertex is well applied to the cervix and always with the fundal pressure. So this diagnosis of this cord prolapse should be anticipated in the setting of rupture of the fetal membranes in various factors, like if the baby is premature, it is very small, or any cord presentation. If you see ultrasonography, you can see the cord presentation just in front of presentation, and you have to suspect that this can prolapse, or any fetal malpresentation. If the fetus has fetus is transverse, or there is a polyhydramnios or twins. In these conditions, you should be very aware, means careful also.
Basically, in every case, we must find out any important high risk factor for the cord prolapse.
Yeah.
And beside that, even we are doing any times we are doing the ARM, we should be kept in the mind.
And what happens is you should not go on palpating that cord. That cord goes in spasm. Many times I have seen that cord goes in spasm, and that again goes for the fetal jeopardy.
So after ARM, we should check by the fetal heart rate monitor.
And bradycardia. There is always a fetal bradycardia after.
There is always abnormalities in the fetal heart rate. So this is very also important thing. So finally, at the end of the discussion, because we have limited time, and all panelists has done a wonderful coverage of important issues related to difficult labor. So one take-home message by each panelist. Dr. Sheila Mane, madam.
Madam, unmute yourself.
Madam Nia? Yeah.
I think earlier we used to learn about, masterly inactivity. Okay. And timely interference. I think we have to really practice that and teach our all the youngsters particularly. And that is the only thing, which will really, really reduce, because one thing is, if it is a active labor, we have to just allow it to progress. We just don't have to do anything, like we don't have to augment, we don't have to accelerate or do anything, because it progresses on its own. Only thing is, we also need patience and the comfort, the respectful maternity care. Okay. Now, the pain relief, whatever protocol we have, we can follow. Epidural is not possible everywhere. But what we have seen, once they go into active labor and full dilatation, they do respond. So respectful maternity care, as well as, the patient's cooperation. So we will have to do a counseling of the patient and tell her that you have to bear. Okay. And, proper assessment. Repeated pelvic examinations are not going to help. Everyone has to learn how to assess the progress of labor, so that we do not bring the patient unnecessarily to labor room. See, we have a pre-labor and a labor room where the patient should be brought only in active labor, so that the patient's relatives are also not worried. There is no apprehension. Hydration is a very important thing. The patient should be well hydrated. Most of the time what happens, she's not taking enough liquids orally as well as. So hydration is a very important part, because the patient gets exhausted. Even if it is a prolonged latent phase, yes, we can give her mild sedation or a painkiller and ask her to relax or move around. And the position during labor, allow her to use whatever position she wants to use. I'm trying it now and my patients are so happy, because, it's like constipation. Somebody has constipation, they know how to apply force and bring out the baby. So you allow her, sometimes she wants to push on one side, that it depends on the position of the occiput, where it is pressing on the pelvic floor. Allow her to push the way she wants to push, And I think the patient will progress fast. Even instrumental delivery incidents will also come. Yes, fetal monitoring is a very important part. So perinatal mortality, morbidity is equally important. When we are monitoring labor, we'll have to take fetus into consideration. Thank you.
Dr. Sharmila?
I will totally agree with Sheila, madam, that watchful expectancy and masterly inactivity will be the key word for obstetrics. And that I think we relearned with COVID. When we did not touch the patient, they delivered vaginally much better. And when the patient comes in night in labor and you're not seeing her much, she delivers vaginally, if you notice that in your deliveries. And the other thing is, in second stage, always remember there's something called a pelvic phase and a perineal phase. Do not ask her to push when she's fully dilated and she's still in the pelvic phase. Only when the head comes down, then the perineal phase of pushing should happen. If she pushes early, and if she wants to push, that's okay, as ma'am said, because the position she's comfortable, she's doing. But you don't ask her to push when she's in the pelvic phase. That's going to cause a prolonged second stage, and most probably it will be a difficult cesarean section also. So in the perineal phase, and when she wants to push, that should be the word, and she should be asked to push only when she feels like, not when you want her to deliver and you want to finish your duty and go off.
Dr. Reena, madam?
My learned co-panelists have already covered most of the things, but what is very important is Mother Nature is kind. Watch for how the labor is progressing. Take the patient's individual characteristics and needs into consideration. And whatever you do, if you do it in the interest of the patient, I am sure you will not get into any trouble. The whole idea is to make labor a pleasurable experience and let it be a pleasure for the patient and the doctor both, so it will have a happy ending. That's all I want to say.
Everything is well, ends in well. So I'm the last person. Everything has been covered very nicely. I must congratulate Bharti to touch upon all the aspects of labor. Now there is a spiritual aspect also. And I think the yoga, meditation, and various exercises earlier our ancestors used to have, that should be brought in, so that though we can allow a companion and respectful maternal care, the woman herself should decide that I should have a normal labor. So for that to build up her mind, so many factors are responsible, I do agree. So her family, as well as her will, her mind, we should prepare so strong that she can bear the labor pains. Only they have so much fear for the labor pains that just getting one latent phase only, they start that we want cesarean. So for that, we also don't have patients or counseling or any PROs. We don't have many. So that factor, every alternate indication in the body is CDMR. So that should not happen. And in future, we will have this aspect also. Thank you very much again.
Yes, so what I could understand with all of you learned persons, that is a beautiful half hour or more than half hour, I don't know how it is spent. So what I could understand that for all these, the woman's preparedness is very important.
Yes.
She should be counseled from very beginning, from antenatal time or before we plan, so that she should not be scared for the normal delivery and pain and preparedness. So she should be counseled that it is a beautiful journey and you can do it. And beside that, of course, obstetricians, what we can do, we can of course we can improve monitoring, we can improve our skills, so that women can have confidence that yes, we can do it. And of course, nowadays there are lots of documentation for monitoring also, so even women can know that her all things are going on well. So definitely she can cooperate more, like CTG monitoring, spartograms monitoring and all. So I am sure that with we are in the, like we were residents, so mostly we had normal delivery. Definitely nowadays the scenario is little bit changed, tolerance is also reduced, lots of things, lots of monitorings, and so, but by all these combined efforts, we can optimize normal delivery. What I can say, that is beautiful for the woman. So by this we comes to the end of this panel discussion. And
must share one thing I will tell you. Yeah. My colleagues are practicing in Kerala. Okay. That hospital is a Shanti hospital, and I happened to meet them recently in Calicut. And I'm surprised, Do you know the cesarean rate in their hospital is only 13%? And then when both of them were practicing obstetric, it was 7%. Their TOLAC success rate, VBAC, is 70%. Okay, that means they are really doing it in a proper way. And Lakshmi, somebody told me, Sheila, ICOG has to really see to it that regarding TOLAC also you can do something. But 13%, means it is possible. It is possible. So everybody just needs will and proper monitoring. That's all I think. So that means what? Nothing has changed. Only we have changed or the patient's mentality. So we have to just follow the nature and allow it naturally to happen. Thank you, Lakshmi.
Thank you.
Bharti, can I say something?
Thank you,
Thank you,
Lakshmi.
Bharti.
It was a
Bharti, can I
really
say
wonderful chai pe charcha. We really need chai.
Yes, as Dr. Sheila has said, where there is a will, there is a way. So I'm so happy and satisfied with all the brainstorming deliberations which just now took place. And I really hope and pray that it should get translated into actually reducing the rates of cesarean section. That is a non-clinical indication. Of course, wherever it is indicated, you all have to go ahead and do it. But as WHO is saying, we all should try actively to reduce the non-clinical or non-indicated C-section. I really wish that we are able to contribute something towards these aims and objectives of WHO, even our government of India and all the stakeholders. So Bharti, well done.
Thank you, madam.
Well done.
Thank you,
I think, Lakshmi, one thing I wanted to say.
Who wants to say
Bharti,
something?
Can I say?
Yeah, Shubhaji.
Yeah. I think implementation of labor care guideline. What we have done, no, Sheila, what we have done is we have given it as a thesis topic to one of our students now, a post-DGO girl. She has taken it up very enthusiastically. Just now we got the approval also from the thesis, protocol committee. And we are comparing it with the WHO patogram.
Very good. That will be a very good study.
So, let us see whether it brings about a difference. I think what we have lost is our courage. We have lost our courage to deliver women. That is why this is happening. And I see the youngsters.
One important thing is, Shobha, it is not only obstetrician. Our midwives in public sector.
Yes.
Midwives in public sector also need to be taught about this. Maximum deliveries happen, and they are the one what Charmila mentioned about the pelvic stage and the perineal stage, the early bearing down and making them exhausted and all that. And then we have seen traumatic PPH happening.
That is where Manyata Lakshya initiative and training is doing a great role in training these midwives and our sisters. So it is a very good initiative of FOGSI, towards reducing the CS rates.
Agreed.
Chalo, so let's call it a day, Bharti.
Okay.
Yeah.
Thank you, Bharti.
You can stop recording. Yeah.
Lakshmi, thanks a lot.
Nah, my pleasure. Keep coming.
Thank you very much.
Lakshmi, you are